I put it on, so we are live now.
We're ready.
Live now.
We're live. Okay. Should we start?
Morning, are we all live?
Yep.
Okay.
So I'm Neil Blumberg. I'm a laboratory-based hematologist, transfusion medicine attending physician at the University of Rochester in Rochester, New York. And it's my privilege to introduce my co-moderator, Linda Shore-Lesserson, who will introduce herself because I don't have her biography on here and I'll probably get it wrong. And she will also introduce our first speaker. Take it away. Thank you, Linda.
Thank you, Dr. Blumberg, and thanks everyone. Welcome and for joining. Thank you for joining us again today for the Bloodless Medicine Society outstanding program that we have lined up on the final day. I'm Linda Shore-Lesserson. As you heard, I'm the immediate past president of Society for the Advancement of Patient Blood Management, SABM. And I am professor of anesthesiology at Zucker School of Medicine at Northwell, Hofstra Northwell on Long Island, New York. And I practice cardiac anesthesiology. And it's my privilege now to be able to introduce our first speaker. And our first speaker is Dr. Malgeet Kaufman. Dr. Kaufman is a board-certified anesthesiologist and intensivist and the medical director of the Institute for Patient Blood Management and Bloodless Medicine at Englewood Health, the world's largest and longest running PBM program at Englewood Health. Her work focuses on perioperative and critical illness anemia, promoting evidence-based strategies to optimize outcomes and minimize transfusion. She's a senior examiner for the American Board of Anesthesiology, and she reviews for the journals Anesthesia and Analgesia, Blood, and Transfusion. Dr. Kaufman also serves on the ASA committees for patient blood management and critical care practice. Dr. Kaufman also develops digital and AI-driven tools to enhance compliance with PBM protocols. And today we're going to hear Dr. Kaufman speak to us about harnessing technology in a bloodless medicine and surgery program to improve outcomes. Thank you, Dr. Kaufman.
Thank you so much, Dr. Shore-Lesserson, and thank you, Dr. Yusoro, and all the wonderful organizers of this program. It's exciting to be here. I do apologize a little bit in the beginning. I worked all night, and so if I mix up my words a little bit or such, it's not on purpose. So this is a interesting topic that I am excited to talk about because it's something I've been working on for the past few years to help just make our clinicians' lives easier and make compliance with the practice of patient blood management, simpler for both our clinical and non-clinical staff. I have no disclosures. So some goals for today. I just want to discuss what are some of the opportunities that we have to support and enhance the pillars of patient blood management with the use of technological aids. What are some concepts that we could apply to both low, middle, and higher resource situations? And also, at the end, I want to talk about what makes successful technological additions and what are some of the pitfalls and downfalls, because we probably have all seen ways that technology enhances our care, and we've also seen ways that it really makes life much more challenging. So first area is optimizing red cell mass. It's what probably many of us in patient blood management spend an enormous time focusing on. We know that from the vast amounts of literature in all areas of medicine that non-anemic patients outperform patients with anemia in basically all outcomes, right? You're young, you're old, inpatient, outpatient, this just remains true. So what are some of the areas that we're using technology for? So one of the things is identifying patients who are anemic early on, especially without a blood draw. So I went through the literature and I found like 3 different, I'm going to call them newer, non-invasive methods that they're discussed. The first 2 are pretty similar. And what I really liked about the first two is they were based on smartphone usage, which has become much more prevalent around the world. The first one was a fingernail-based hemoglobin estimation with using a smartphone photo of the nail bed. What's nice is about nail beds is there's very little melanin, so the underlying blood color is actually easier to analyze based on photography. Machine learning models can estimate the hemoglobin, and with calibration to lab data, it can actually get to an accuracy about plus or minus 1 gram per deciliter. So it's probably more useful for screening or trending, but not really reliable for high stakes clinical decision makings. The second one also relies on smartphone photography, and it's a picture of the conjunctiva. It's a photo of the inner eyelid, which is processed to measure redness or color ratios that correlate with hemoglobin. Again, these models detect anemia well, especially at low hemoglobin levels, but with accuracy about 1 to 1.2 gram, plus or minus 1 to 1.2 grams per deciliter. And like that fingernail method is, again, probably better for screening or population assessments rather than like precise management. The third one is, we've probably spoken about it here before in other BMS lectures, was this non-invasive spot hemoglobin measurement. It uses multi-wave spectrophotometry via finger sensor to estimate hemoglobin concentration in the blood. There's some more mixed data on the use of this, especially in the preoperative or intraoperative phase. It's probably a trending technology to minimize transfusion usage, and it may be helpful to identify patients who present preoperatively to see as a screening tool, are they anemic and need to be addressed earlier. It is possible that higher levels of melanin might be affecting this technology, though they do have some data that shows that it's not a major issue. Overall, these technologies offer some promising low-cost ways to screen for anemia, but they're really not replacing hemoglobin testing when accuracy is critical. So I actually tried to summarize the data for these non-invasive technologies, comparing them from the bedside anemia screening and comparing them to a bedside anemia screening to a HemoQ, like that spot, but invasive anemia. So these non-invasive devices and the smartphone apps, both with, just to note, Apple and Android had very similar outcomes so the cameras were not that different. So these non-invasive technologies did demonstrate very high usability and acceptability. So people were more than happy to try it and use it, but overall this poor diagnostic accuracy and overall correlation with that reference, if you see those correlation of values of R-squared values. And so it probably overall limits their effectiveness for clinical anemia screening on an individual patient level, especially when we compare it to more invasive measures such as HemoQ, which showed overall stronger correlation, minimal bias, higher accuracy, and good usability still. So probably still have to rely on the older technologies, but it's interesting that things are coming out. So moving on to that next concept in anemia identification, I actually have to give a hat tip to Josh Moriello, who introduced me to this concept. The old way was a patient had labs done, a clinician needed to review them. If the patient was anemic, the doctor had to add on appropriate anemia labs. Hopefully they saw them within 24 hours, so the lab would do it, or the patient had to come back and have more blood work drawn. And again, adding more time and cost to the patient. But there actually is an automated process that can be created with the lab during the initial order. So we created something called a CBC with reflex anemia testing. And if the patient's found to anemic, an automatic process will automatically add on labs. People might be more familiar with this when we do TSH testing with, reflex thyroid level, hormone levels afterwards. So if the patient's found to be anemic based on their MCV levels, we will add on appropriate iron panels, ferritin, creatinine, reticulocyte, but only if anemia is present. So this actually is saving our clinicians a step. So if anemia is identified, usually it's all done within an hour's time. So by the time they actually get back to check the labs, especially if it's an outpatient setting, everything's already sitting there. Just of note though, if the patient's not anemic, it does end up wasting a tube and some blood from the patient if that reflex testing wasn't available. So this is the workflow that we introduced in our automated system. And when I started this initially, I thought, oh, this is going to be such a simple task. What's the big deal, right? I should have known. It had months of work behind the scenes, working with lab, IT, billing, compliance to actually get this up and running. And to minimize the waste of tubes and not overwhelm our lab system with this reflex testing, we specifically wanted to make sure that this test was only being ordered on very targeted patient populations. So we focusing it on our pre-procedural, pre-operative patients, our OB patients, and our heart failure patient. So again, some of our large successful integrations of technology have been simpler, but that's sometimes what makes them really nice. The main goal is trying to make things simple and easy for our bedside clinicians so that they could practice patient blood management accurately. So within our EMR system, there are multiple different flow sheets, and we were actually able to customize our own anemia management flow sheet. And this brought all the relevant information onto one screen so our clinicians can identify trends, ensure that the treatments are being initiated for this. And in one view, they could see the entire hospitalization. They could see all the medications, and they can antiplatelets, anticoagulants. They could see all blood transfusions. And this global view is actually able to help them spot trends in areas that need attention. At the end of this talk, I'm going to talk about the criteria for successful use of technology. And this flow sheet hits many of them: the seamless integration, easy to use, and actionable data. On a larger population area, there is the presence of proprietary software that helps healthcare institutions identify their anemic patients. So they have softwares that use algorithms that integrate into EHRs to automatically pull out anemic patients and automate much of the manual processes of treating anemia. In a 2024 abstract, My Blood Health was actually able to show that after implementation in over 70 hospitals and screening of over 484,000 patients, that the patients who were managed prior to procedures had a 25% reduction in length of stay and an 83% reduction in transfusion rates, and a 91% reduction in readmission rates compared to the untreated matched patients. The number of patients they were able to treat was dramatically higher than relying on traditional manual methods of reviewing each individual chart. And again, I realize that some of these are more expensive options, but there are lower cost options that many people can do to help to organize, but while manually performing these processes to share relevant information with all of our clinicians. So next pillar talking about in patient blood management is minimizing blood loss and making sure that we're maximizing use of the appropriate treatments. So how do we make sure that the correct equipment is getting to the correct patient? Especially as our ORs get busier, as our departments get larger, it's actually harder to maintain these higher levels of compliance. And thankfully, with the vast amounts of data available and with training by department leaders, this is actually a key area that AI can assist clinicians to help identify patients who would benefit from having devices such as cell salvage or using techniques such as A&H early on would be appropriate. I'm not going to get so much into the AI specifically because I know there's going to be an amazing talk later today about AI, but I think this is actually a huge area that we could be using as well. In addition, when hospitals or institutions have limited resources, this OR scheduling aspect can be optimized to make sure that they have enough equipment available when these cases are scheduled. Just to give you an example of what we are using for, so we have a clinical decision support integrated app within our EHR, which has AI capability. And what we're able to do is actually do this pre-op synopsis on our patients. And it can risk stratify patients. It can make suggestions for appropriate equipment, for any labs that are missing. So we're already doing it. We haven't done much training to say, oh, surgeon X, this procedure is higher blood loss or lower blood loss or things like that, but there is capability that's there. Other areas of real-time use. What happens when emergencies? Can we identify emergencies earlier? So there's actually been development and validation of the Bleeding Artificial Intelligence Detector, the BLAIR system, and it's based on an AI tool to predict and identify intraoperative bleeding during robotic radical prostatectomies. It uses a technology called multitask learning convolutional neural network. Sorry, I don't completely understand the science behind this programming aspect. But it basically is analyzing surgical video and classifying if that frame has either the absence or presence of blood accumulation. In clinical assessments, this Blair technology was able to recognize bleeding with an accuracy of over 90%. And when it compared to expert urologist, Blair was able to identify bleeding, which was basically statistically indistinguishable to expert urologist, and actually did it faster though. And their research has confirmed that there's been really no significant difference in Blair and human assessments overall though. Once there is bleeding and emergency care is happening, how can we make that clinical decision support safer and faster? There's a growing literature that we know that viscoelastic testing improves outcomes and compliance with goal-directed transfusion and treatment. But what if clinicians don't routinely use viscoelastic testing? I know in our department, our general anesthesiologists maybe use it once or twice a year. So again, as talking about these integrated clinical decision support tools, we've been able to ease that process of interpreting a tag. And we customize it with our own internal recommendations for treatments. In the future, I actually hope to use AI tools to train the app to read the graph of the tag and not require manual, entry of the numbers or answering questions, does the CK curve split before 10 minutes and stuff. But the technology is there to start to do this and to help our clinicians make treatment decisions faster and more appropriately. And what we've been able to do with this is we simplified this decision tree into a very just simple answer, yes, no questions. And what we've seen from starting this clinical decision support system is that our use of TEG has dramatically increased and sustained since we've rolled this out compared to our previous ways that we were doing viscoelastic testing. And lastly, I want to talk about some newer techniques in monitoring our anemic patients. We know that anemia is just not about a number. It's about the pathology of oxygen consumption and delivery mismatch. So how can we identify patients who are most at risk? This concept, we know that lactate has never been the perfect idea to do it. So what are some other things that we're using to help there? So we know that oxygen delivery monitors, what they're trying to do is assess the adequacy of tissue oxygenation and determine if that patient with anemia is physiologically tolerating their condition or actually experiencing negative effects that need further intervention. And so these monitors are either doing direct or surrogate measurements of oxygen delivery and consumption. And so it's a move beyond this concept of hemoglobin thresholds to really more that individualized physiological approach to patient blood management. And so some of the newer technologies that are out there is NIRS. NIRS is a non-invasive measurement of regional tissue oxygenation. Most of the literature that I was able to find is really more about neonatal care, trauma, and cardiac surgery. And NIRS can detect changes in tissue oxygenation related to anemia and with transfusion. But again, sensitivity and specificity still remain limited. Central venous oxygenation saturation along with oxygen extraction ratios. And so these are more invasive monitors, though, that reflect that balance of oxygen delivery and consumption. There are some studies that show that using this technology could better identify patients at risk for tissue hypoxia and lead to improved outcomes. AV oxygen differences, and then muscle oxygenation myoglobin. This is probably the more emerging non-invasive technology to measure intracellular oxygenation and providing a more direct assessment of tissue oxygenation. Early data showing it might be helpful, especially in oncologic or pediatric patients, but this is not yet fully out there for prime time. So as mentioning that NIRS it's basically it's a small sensor that shines near infrared light through the skin, and the light behaves differently depending on whether the hemoglobin is carrying oxygen or not. And so by analyzing the light that comes back, the device actually is able to estimate the amount of oxygenated blood. So in other words, NIRS is trying to give us a real-time window into whether tissue is getting enough oxygen, which helps us understand whether our patient's tolerating anemia or is in shock. And it does pretty well correlate with hemoglobin levels. There have been about 4 randomized controlled trials with about 500 patients in them, using NIRS to guide transfusion. And it does seem to reduce the overall number of red blood cells units given, but doesn't actually change overall if a patient gets transfused or not transfused, or overall clinical outcomes. So again, NIRS is promising for assessing anemia tolerance, but the current evidence isn't strong enough for widespread adoption, and we still need to standardize thresholds and better understand how this tissue oxygenation relates to outcomes. Central venous oxygenation saturation. So a 2023 systemic review and meta-analysis by Pudagio, it compared the red blood cell transfusion strategies graded just by hemoglobin alone versus those of integrating other perfusion markers, specifically the central venous oxygenation in adult cardiac surgery patients. There were only 2 really excellent trials, randomized controlled trials, and they only had about 257 patients. But again, when we start to use these other markers, it reduced overall the total number of packed RBCs transfused and the proportion of patients transfused when you compare to only hemoglobin monitors. But there still overall was no massive significant difference in like mortality, ICU, or hospital length of stay, or post-op complications. So this is a bit of a summary of the different oxygen monitors, such as NIRS and the myoglobin, in supporting more physiological transfusions. Again, they seem to be safe and effective, but I don't think we fully have the standardization there, because of some weak correlations in some areas. And so again, I think it's improving and we're getting better, but it's still a work in process. And just as a summary, how do you know if something's worthwhile or not worthwhile? These are some things that I think about when we're going down these tasks. What is something that's going to make us successful use of technology? Seamless workflow, right? No one wants to be switching back and forth between multiple screens, opening up multiple apps, things like that. You want that minimal disruption. You want it to exist, that things work together very well. You want things to be user-friendly, easy on the eyes. It should be intuitive, minimize the number of clicks, very clear alerts, not doing too many alerts, or alarm fatigue. Data needs to be real-time, actionable. You need immediate feedback, especially with those clinical decision support tools. And there has to be audit and feedback mechanisms to constantly know how it's working and improving. And what are things when you should look about when it's probably not going to work well? Poor integration with clinical workflows. If it requires a lot of extra steps of clinician, it's not going to get used. It has to be perceived as usefulness. You have to find out where are the weak points, where do people want help? If there are technical usability issues, if the viewers don't open, if things are already crashing, it's not going to be. People are very threatened if it threatens their professional autonomy. People do not want to integrate technology into their life if it does that. There still seems to be some mistrust of these clinical decision support systems, so that's something as well. Alert fatigue is absolutely, you need to make sure people are trained and comfortable, and also that organizational readiness to integrate these things and to support them. And with that, I'm going to end my show, and I'll stay on for questions at the end.
Thank you very much, Dr. Kaufman. Much to think about for our future, and I'm sure there'll be a lot of questions for how can we apply all of these interesting technologies to make our patient care much more efficient and keeping up with the times. Thank you so much for that. It's now my pleasure to introduce our next speaker, and we will take all questions at the end, after our third speaker. So it's my pleasure now to introduce Dr. Kelly Johnson Arbor. Dr. Johnson Arbor is a board-certified physician in emergency medicine, medical technology, toxicology, and undersea and hyperbaric medicine. Currently, she serves as the medical director of hyperbaric medicine at MedStar Georgetown University Hospital in Washington, D.C. Dr. Johnson Arbor maintains medical toxicology and hyperbaric medicine clinics at MedStar Georgetown University Hospital and regularly teaches medical toxicology and hyperbaric medicine topics to third and fourth year medical students, residents, and pharmacology students. She's an associate faculty member of the MedStar Institute for Quality and Safety, MIQS. She's active in professional medical societies, including the Undersea and Hyperbaric Medicine Society. Dr. Johnson Arbor is an instructor for introductory hyperbaric medicine courses, has authored multiple published medical articles on toxicology and hyperbaric medicine related topics, and she enjoys speaking on these subjects as well. Her current research interests include heavy metal poisoning, the impact of hyperbaric oxygen administration on eustachian tube function, and the use of hyperbaric oxygen therapy in the bloodless medicine population. So fascinated now to introduce Dr. Johnson Arbor to talk about hyperbaric oxygen therapy, the occasional technology in bloodless medicine.
Thank you so much, Dr. Shore-Lesserson, and thank you for inviting me here today to speak about hyperbaric oxygen therapy. It is occasionally used in bloodless medicine. I personally think that it should be used a lot more. And this is more of an older technology. It's not anything emerging, as Dr. Kaufman was just discussing, but it's something that's been around for a while that is used mostly for other conditions in medicine, but I love to use it in the bloodless medicine population, and I hope that you will too. So we're basically going to talk about why hyperbaric oxygen therapy works in the bloodless medicine population, how we can alter oxygen delivery and extraction to tissues by use of hyperbarics, as well as basically the risks and the benefits, and also just how it works. All right, so when we talk about what is hyperbaric oxygen therapy, there's a lot of different ideas and definitions that are out there. And if you do an internet search, you'll see all sorts of different pictures online. Basically, this picture to the far left, this person that's enclosed in this kind of glass-looking tube, so that is a single person hyperbaric chamber. The picture on the middle left is a multi-person hyperbaric chamber. And then these two things on the right are not really hyperbarics. So the fabric picture with the, it looks like a child and the child's caregiver, this is something called mild hyperbaric oxygen therapy that is gaining a lot of traction and interest in the US because a lot of celebrities use this and endorse it. Some of our favorite professional athletes like LeBron James have announced that they use this technology, but it's not really the same as hyperbarics. Because you're not getting 100% oxygen and you're getting pretty low treatment pressures. And then finally, this device on the far right is a pretty much like a plastic box that this individual has their leg in. This is topical oxygen therapy. So this is also not hyperbarics. So the true definition of hyperbaric oxygen therapy is a treatment where the patient is breathing 100% oxygen while they're enclosed in a treatment chamber that is pressurized to greater than sea level. So the two key things here is that you have to breathe the 100% oxygen and you have to be physically enclosed in a treatment chamber. So topical oxygen is not systemic. This is not your whole body being enclosed. That does not qualify for hyperbarics. And these mild chambers, I love to talk about this therapy because it's actually really, really interesting to me and how it was developed and how it's marketed. But basically, this involves using treatment pressures just barely above sea level, maybe like 15 feet underwater equivalent. And you're also breathing about like 29 to 35% oxygen during this treatment. The proponents of mild hyperbarics say that it offers the benefits of high levels of oxygen without the adverse oxidative damage associated with traditional hyperbarics. But because of that, you are getting less oxygen. And so physiologically, it doesn't really do the same things as traditional hyperbarics. It has not been proven scientifically in the medical literature to have the same clinical benefits as traditional hyperbaric oxygen therapy. So neither of these two devices represent hyperbaric technology. Hyperbarics is also very different than scuba diving. So here's a scuba diver. They look like they're diving for fun, so they're a recreational diver. Recreational scuba divers, for the most part, are breathing compressed air. Now, if you're really advanced, you may breathe some other combination of nitrogen and oxygen. If you're diving really, really deep, you might add in some helium because it's inert. But recreational divers that go on vacation and dive, to depths of less than 130 feet are going to be breathing compressed air. The physiology of compressed air, because it contains mostly nitrogen, is very different from the physiology of oxygen in the human body, and the toxicities are different as well. So I don't like it when hyperbaric treatments are referred to as dives, because it's very inaccurate. That, number one, makes the patients think that they're going underwater, which they are not. And also the physiology and the toxicity of the gases that the individuals are breathing is very, very different. In terms of hyperbaric physiology, we see hyperbarics being used a lot in wound centers. And the reason for this is that the hyperoxia induced by hyperbarics causes this increased gradient for oxygen diffusion between tissues. So if you're somebody that has a chronic wound, like a chronic diabetic foot wound or something like that, chronic wounds by definition are hypoxic. And so if you deliver a large amount of oxygen to that area, you get this increased gradient for oxygen to diffuse from the hyperoxic area to the hypoxic area. This in turn causes increased reactive oxygen and reactive nitrogen species, which promotes stem cell activity, which in turn then promotes VEGF and endothelial cell activity. And your end result is that you get neovascularization. So when we use hyperbarics for treating patients with chronic wounds, we're doing it because we're inducing this new blood vessel growth that occurs over time. This is, again, why you see us using hyperbarics a lot for wound care. So these are just some patients that we have encountered throughout the years at my hospital. This is a patient that has a surgical incision that's a little bit dusky at this lower skin flap. So this is an example of skin flap ischemia. And patients like this, the random nature of the skin flap vasculature is not able to support enough oxygen delivery to heal the skin flap. And so we put the patient in the hyperbaric chamber for a few days to maybe a couple of weeks to try to deliver more oxygen to that skin flap to heal that wound. This next picture on the right is somebody who went in for what I believe was a bunionectomy, and they came out of the OR with a purple looking toe. And in this case, there was some sort of event intraoperatively that caused the patient to have acute peripheral arterial ischemia. And this caused the toe to turn necrotic. And again, in this case, we put the patient in the hyperbaric chamber, typically for just a couple of days until that toe pinks up again. Finally, here's another example of a skin flap compromise. This person had a cranioplasty, and you can see that the skin flaps are pretty necrotic. So again, we use hyperbarics a lot for wound care, and in the majority of hyperbaric oxygen facilities within the US, you will see them located within outpatient wound care centers, and they're going to be doing a lot of stuff like this. Actually, probably a lot more treatments of diabetic foot wounds, because that's the ideal target population in many centers for hyperbaric oxygen therapy. But you can use it for other things too. So there's a bunch of different traditionally accepted indications for the use of hyperbaric oxygen therapy. These are going to differ based on locality, but in the United States, this is typically what's covered by insurance and what is considered medically necessary by the FDA for hyperbaric oxygen therapy administration. There's only two conditions where hyperbarics is actually needed. And a lot of people do gravitate towards hyperbarics because it's sort of perceived as like this newer technology, even though it's not. And it's kind of, attractive, and it's different, and it makes you feel special. But most people do not need hyperbarics, with the exception of these two groups. If you have an air embolism, hyperbarics is a primary treatment. And if you have decompression sickness, hyperbarics is primary treatment. Everything else, we're an adjunctive treatment. So we're there to help, but we're there to help in addition to the other treatments that are being used. And so in bloodless medicine patients, we are used in addition to IV iron and EPO and all the other therapies that are out there. So a bunch of other things that we use hyperbarics for, ranging from carbon monoxide poisoning to sudden hearing loss. You see severe anemia on there, compromised grafts and flaps, and then all these different types of wound healing. So this is traditionally what we use hyperbarics for, but I will tell you that most hyperbaric centers in the US are going to treat mostly delayed radiation injuries, diabetic foot wounds, and maybe some compromised grafts and flaps. And that's pretty much what they focus on. A lot of people don't really understand how hyperbarics is used to treat anemic patients, and they also don't understand how to apply hyperbarics to the anemic patient population. but we're going to talk about that now. So just to review for all of us, we all know that hemoglobin is the major carrier of oxygen in the human body. The amount of oxygen that is delivered to the human body is going to depend on two things: how much blood your heart is pumping, as well as the amount of oxygen in your arterial circulation. And there's an equation that demonstrates this. It's right here. So generally, we don't want to increase somebody's cardiac index too much, because if you can actually, theoretically put somebody into heart failure if you try to get their heart to pump faster and faster and faster to get more oxygen throughout their body. So we really want to focus on optimizing the arterial oxygen content here. So why do we do this? Basically, oxygen that's delivered to tissues is extracted by the tissues and then used. On average, our body is going to extract this magic number of about 5 to 6 volume% of oxygen from the blood. When our oxygen supply equals demand, it's fine. Our bodies are happy. We can function fine. But in anemic patients, your oxygen supply is probably, in many cases, not going to meet the physiological demands. And that's when we get the signs and symptoms of oxygen debt. When our hemoglobin concentrations go below 6, oxygen delivery and extraction become unequal. And this is, where we typically see patients being transfused to enhance their systemic oxygenation. When hemoglobin drops below 4, this is when patients become typically very altered and confused and might have some cardiac ischemia. So in patients who are severely anemic, you can manipulate the arterial oxygen content equation to improve oxygen delivery. And traditionally, we can give blood transfusions. But if you cannot get a blood transfusion for whatever reason, you can still manipulate that arterial oxygen content to your advantage through the use of hyperbaric oxygen therapy. The arterial oxygen content, again, is going to be mostly dependent on hemoglobin. This is reviewed for all of us. Each hemoglobin molecule can carry a fixed amount of oxygen, and there's a very, very small amount of oxygen that's dissolved in our plasma. This is the arterial oxygen content equation. Normally, oxygen bound to hemoglobin is what we're going to focus on. So that, again, is why we transfuse, and we sort of ignore that plasma dissolved oxygen component of the arterial oxygen content equation because it's so, so tiny. So our PaO2 times 0.003 is going to be a tiny, tiny number for most of us, whereas our hemoglobin concentration multiplied by 1.34 is going to be a larger number. So that's why we transfuse. But if you can't transfuse, you can actually focus on that plasma dissolved oxygen. And through hyperbaric oxygenation, you can greatly increase the amount of oxygen in the plasma. And even when you multiply it by that 0.003 factor, you do have enough oxygen dissolved in the plasma to meet your body's oxygen demands. How does this work? Well, it's basic physics. So over here in the US, it's early in the morning. I don't want to put any of you guys to sleep, but just know that hyperbaric oxygen therapy can greatly enhance oxygen in the plasma because of Henry's law, which is the law of solubility. So Henry's law says that as the pressure increases, the amount of gas dissolved in any liquid solution is going to be directly proportional to the partial pressure of that gas. So if you are a scuba diver, for example, you are going to be breathing air. And when scuba divers breathe air and they dive deep, they, because of Henry's law, more of that nitrogen in the air dissolves in their blood. And so when scuba divers come back up to the surface, they have to make a decompression stop or a safety stop to off-gas that nitrogen so that they don't develop decompression illness. In the hyperbaric chamber, we don't have to worry about nitrogen, again, because our patients are breathing 100% oxygen. But when the pressure increases in the hyperbaric chamber, all of that oxygen is going to dissolve in the plasma. And that is how you can enhance your arterial oxygen content. If you check a blood gas on patients, like those of us right now who are at sea level breathing room air, our maximal PaO2 is going to be about 100 millimeters of mercury. Under hyperbaric conditions, you can exceed 2,000 millimeters of mercury. When you multiply 2,000 by 0.003, which is, remember, that 0.003 component of the arterial oxygen content equation, you get that magic number of 6, which is the amount that you need to have your oxygen demands meet your supply in your human body. So by putting somebody in a hyperbaric chamber at 3 atmospheres, which is the equivalent of going 66 feet underwater, but pressurizing them to 3 atmospheres, you can actually basically meet their body's metabolic demands for oxygen without having any hemoglobin in your body. So that's why we use it. Here's some pictures of hyperbaric chambers. There's a couple of different types of hyperbaric chambers. Again, this is a single person chamber. This is actually one of our chambers at my hospital. The picture on the right is a multi-person hyperbaric chamber. The single person chamber could only hold one person. The multi-place chambers can hold up to 15 or 20 or even more patients. And in the US, most of the chambers that we have are these single person chambers. The multi-person chambers are much more extensively they're more expensive to install. They're very extensive. They have to have a built-in fire suppression system directly underneath them. And there's a lot of work that goes into those. And so because of cost issues and staffing issues, most hospitals prefer to have the single person chambers. Again, hyperbarics is able to provide enough plasma oxygenation to meet the body's metabolic demands. And so this is why we want to consider the use of hyperbarics for anemic patients who can't get transfusions of blood products. The deeper that you go, the more oxygen you get, but the deeper that you go, you also are at risk for more side effects from hyperbarics. So we typically will treat these patients to somewhere between 2 and 3 atmospheres. The oxygenation is transient, so these patients sometimes need to come in more than once a day for treatment, and they typically do need to come in for maybe like several days to a week. Once in a while, if I have a patient who's really symptomatic and we're really trying to get their hemoglobin up from a low value, like 2 or 3, we'll bring them in for 3 to 4 weeks of treatment. There's only in the medical literature a small number of case reports and case series about the use of hyperbarics for people with acute blood loss anemia. And I think because of this, a lot of physicians and clinicians are sort of reluctant to use hyperbarics for this patient population. There's no defined treatment protocol, but again, it's very simple. We basically tailor it to the patient's needs. And I think it is actually appropriate that there's no protocol for this because every patient has different needs and every patient's physiologic needs and degree of anemia are going to be different. So I normally tell patients when they come in for bloodless medicine treatments with me, I say plan for a week or 2 weeks. You may need less, you may need more. We're really going to go based on what your labs show. We stop treatments when the patients are asymptomatic, when their EKG changes resolve, when their hemoglobin goes above 7 or whatever threshold we want to use, and when they are feeling better. And again, like I said before, this is an adjunctive treatment. We do use hyperbarics in combination with other standard techniques like IV iron and recombinant human erythropoietin. Hyperbarics is not completely benign, so that's why you have to have a physician nearby. There are side effects, mostly due to barotrauma. So these pictures basically show the air-filled spots in the human body. So you got your middle ear cavity, your sinuses, your lungs, and your GI tract, and all of these are potentially susceptible to barotrauma. When the pressure increases, this goes back to the ideal gas law. Pressure and volume have an inverse relationship. When the pressure increases, any air-filled space in the body will decrease in size. So your middle ear cavity will shrink, your lungs will shrink, et cetera. But when the pressure decreases, all those things will enlarge in size. So you have to be concerned about things like middle ear barotrauma and pulmonary barotrauma that can potentially be very serious. Oxygen can also be toxic, just like everything else in the world. If you breathe too much of it, it can cause seizures. The oxygen over time can cause temporary myopia in certain patient populations. In patients with underlying heart failure, the central vasoconstriction induced by hyperbarics can actually be significant and increase patients' risk for flash pulmonary edema. Here's a picture of the middle ear cavity. Again, when the pressure increases, the middle ear cavity is going to shrink in size. Your eustachian tube will collapse. If you're not able to yawn or move your jaw from side to side to equalize these pressures, your eustachian tube will stay collapsed and you'll have a lot of pain in your middle ear and you won't be able to equalize your ear, and that's no fun for anyone. This picture on the right is an individual that was a smoker for a long time, and they have some, it looks like some paraseptal and some centrolobular emphysema here, which is something that we also do not want in the hyperbaric chamber, because if those little cystic areas rupture, the patient will get a pneumothorax. And when we decompress the chamber, again, that air-filled pneumothorax space is going to increase in size, turn into a tension pneumothorax, and the patient could die. So I do a lot of chest CTs and other chest imaging on my patients, especially if they have any lung issues or are smokers, and patients who have difficulty equalizing their ears on airplanes or are very, very young or have cognitive issues where they can't communicate that well. They get sent to ENT for consideration of tympanostomy tube placement so that they won't have difficulties equalizing their ears during hyperbarics. We also have to be very, 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 very careful about fire safety. Safety is very important in the hyperbaric environment because we are using enriched levels of oxygen. So by definition, anything greater than 23.5% oxygen constitutes an oxygen enriched environment, and the risk of fire goes way up. We have to follow very strict fire safety standards. People that do not follow those standards are at risk of experiencing fires with death, 100% chance of death in the hyperbaric environment. And sadly, in the United States, that's actually happened twice this year because there's a lot of unregulated hyperbaric centers that are out there, like in strip malls and wellness centers, where they don't follow these very basic safety standards. And when that happens, the chambers catch on fire and people die. In the medical setting, we are pretty strict again about this. We conduct safety checklists before every treatment, and we basically don't allow patients to bring things in that could be combustible or could potentially spark a fire. To have a fire, you need an ignition source, you need something to burn, like some fuel, and you need oxygen. In clinical hyperbarics, we cannot minimize the amount of oxygen because that is our drug that we are giving our patients. So we have to minimize anything that could burn and anything that could be an ignition source. Luckily, we do have a guide for that. The National Fire Protection Association in the US is the organization that sets fire safety standards for healthcare facilities. Their standard book is published every 3 years. This is a very old version, as you can tell, but there's actually a dedicated chapter in the NFPA healthcare facility standard about hyperbarics because it is so fire safety sensitive. And that standard basically defines what can and cannot go in a hyperbaric chamber. So in most hyperbaric chambers, you'll see signs like this that talk about what cannot go in. And these are all things that could potentially be risky in terms of fire safety. So that is pretty much it. So just to wrap up, now we all know that hyperbaric oxygen therapy involves enhancing patients' plasma dissolved oxygen, and it's administered in treatment vessels that are pressurized or greater than sea level. And then we need to consider the use of hyperbarics in the bloodless medicine population when patients can't get transfusions. It's a great technology. It's in a lot of hospitals around the US and the world, but it is definitely underutilized because a lot of people just don't recognize that it can be used. Most adverse effects can be successfully mitigated with very careful patient selection and treatment population, but we do need to be very careful about fire safety. And so that's why I always tell patients and other physicians, if you go to a hospital setting in the US for hyperbarics, you will be fine, but do not go to those outside places in the wellness centers in the community because that is where bad things have happened. I will also stick around for questions at the end, but you can always call me or email me with any questions also. And thanks again.
Well, thank you, Dr. Johnson Arbor, for that fabulous talk. Most of us are not terribly familiar with HBO and its potential role. Thank you. Our next speaker, who's sharing his slides now, Dr. Aryeh Shander, is really well known. I think if there's anybody who doesn't need an introduction, it would be him. And in order to get a little bit back on time, I'm going to keep this short. But I've known Dr. Shander for several decades. And for those of you who are perhaps under the age of 60, you may not realize what his journey has been. And in the United States, he and Sherry Ozawa and their team at Englewood Hospital, which is a teaching hospital in New Jersey, basically invented in the United States, to some extent, bloodless medicine and surgery. And then patient blood management. And they're probably the only hospital for quite a few years where all of the patients were treated as if they were Jehovah's Witnesses to some extent, and trying to avoid the very toxic and not terribly effective therapy of transfusion. And I won't go into great detail. So Englewood was really a great center of learning. Our own team learned most of what they knew about this by going and visiting with them. They were receptive for visits from all over the world and made an enormous impact, particularly in the United States, but also internationally. Dr. Shander was the chair of anesthesiology, critical care medicine, pain management, and hyperbaric medicine at Englewood, and also has current faculty appointments at the Rutgers, New Jersey Medical School and the Icahn School of Medicine at Mount Sinai. And so he's made extraordinary contributions to the field of medical care, particularly in the area of bloodless medicine and surgery, but also patient blood management. And it's a great privilege to introduce him. And I'm not going to say any more, Arieh, because you'll be embarrassed since you're so modest, and also because we need the time. Carry on.
Thank you, Neil. Again, thank you for that very in-depth and sweet introduction. Again, thanks. Yes, we have been friends for many years now, looking back at decades. But again, your contribution to this area is something that also should be mentioned. So I'll move on because of time and talk about bloodless medicine and surgery. Again, this talk talks about the importance of bloodless medicine and surgery, which is after this particular conference. I think it's always important for us to remind ourselves why we're here, how we got here, and where, of course, we're going to in the future. Let me just say that this particular presentation, similar to it, was also given during the annual meeting at the Society for the Advancement of Patient Blood Management, SABM. And the importance here in terms of why it was given is because the leadership, including Linda and Matt, all felt very strongly that we need to remind our audiences about the importance of bloodless medicine and surgery. So for this particular talk, I have no disclosures except for one. Let me see if I can advance my slides. And the disclosure essentially is that this talk is not going to be about what Neil just introduced, which is the whole issue of the New Jersey Institute for the Advancement of Bloodless Medicine and Surgery, which we have been promoting, if you will, as not just a center for bloodless medicine and surgery, but also looking at it from a more scientific point of view and being able to help other patients, not just those patients where blood is not an option. I would turn your attention to the URL below if you want to see more and if you want to see a great historic progression of how we got to where we are. The birth of Bloodless on YouTube is something that is exceptional as far as I'm concerned, and I urge every one of you to review that. I think this will be very interesting in terms of seeing how the evolution of BMS or bloodless medicine occurred. So everyone is very familiar with the three-pillar concept of patient blood management. But I think that pictorially looking at this, you need to look at where the foundation is. And of course, the pillars need to stand on a foundation. And this enormously strong foundation happens to be BMS. You see that there's also a roof, which we'll address as we progress through this talk. But I think it's very important for us to understand that there is a strong foundation for patient blood management, which starts with bloodless medicine and surgery. And how do we start? Well, it was defined in many ways as unmet need. It was an unmet medical need for a specific community, the Jehovah's Witnesses. Those are patients, again, as we now have redefined as individuals for whom blood is no longer an option or was never an option in terms of treatment. In the past, the method of receiving care for witness patients was through something called cooperative physicians or cooperative healthcare providers. Unfortunately, what that did is put them at risk because although there were one or two cooperative individuals within an institution, the whole culture of the institution was that blood saves lives, and therefore, if you are declining a blood transfusion, there must be something wrong with you, or that you're essentially don't understand what good care means. So you could see that there was a push and pull during those times, and in many occasions, patients were actually forced or coerced to receive blood transfusion, despite the fact that they were actually managed by a cooperative healthcare provider. During this time, blood was used by many in healthcare or overused in many in healthcare by many times, even though there was no science behind it. Everybody felt that, quote unquote, it was a lifesaver. And at the same time, we're also topping off patients with blood just to make them a little pinker, etc. I'm not going to go through all of that, but as you all know, the culture of blood use still prevails today, something that we're trying to change and help healthcare providers understand the relative benefit versus risk when it comes to that. But two forces collided during that time, which resulted in recognition of the bloodless concept. One was that blood became clearly inherently dangerous. During the HIV and hepatitis C epidemic, blood became unsafe, so that those people who were already using blood culturally, if you will, had to step back and redo their practice. And what they did is they tried to refrain from using blood, but had no tools, again, to care for those patients. But what seemed to be evolving at the same time was the growing community that viewed medicine positively, meaning they wanted everything that medicine could provide, but declined any major blood component use. That seemed to be in many ways a contradiction for many in healthcare, but in fact it wasn't. It became synergistic. So the opportunity seen by enough clinicians to organize brought us organizations which were called bloodless medicine and surgery organizations. Just to step back to show you that the contaminated blood scan in England, this was a publication you see from 2025. This is early this year. So this is still resonating within the healthcare community. So the threat, if you will, of unsafe blood is still there. We look back at it and need to understand that blood may not have all positive effect and that we need to be concerned with it. No question that the use should be curtailed to only when actual benefit can be demonstrated. In the same time, optimized bloodless care. This is in cardiac surgery for Jehovah's Witnesses. You could see this publication was in 2022, showing that emergence evidence suggests that surgical outcomes of patients undergoing cardiovascular surgery that decline. You see, we've changed the word refuse because it's so negative, and it creates dissonance between the healthcare providers and the patients. I think decline has, again, denotes the fact that patients have a choice to either accept or decline therapy. So just to step on this particular concept, you can see that autologous transfusion is comparable to those who accept whole blood products and transfusions. So at least we have, in some of the literature that we published, we have some equivalence, if you will, or non-superiority, if you like to look at it from that point of view. But in fact, there are many publications showing that there is actually superiority. So going back to the concept of bloodless medicine surgery, I think we need to see and step back to see how this evolved. And we need to start with someone who saw the opportunity many years. And this brings us to Dick Spence, who passed away last year. Dick clearly was a pillar in organizing clinicians in a scientific way, but also in a moral and ethical way, to be able to provide people, number one, with the right choice for their healthcare, but additionally also trying to put some science behind it so it would be acceptable to all clinicians to apply this to their patients if the patients decline transfusion. And you may know this organization, ATA, as that you see on today's logo over here, saying that Network for the Advancement of Patient Blood Management, Hemostasis, and Thrombosis. But don't be fooled, because that's what NATA was stood for at the time when Dick Spence and others put this organization together. So the Network for the Advancement of Transfusion Alternatives is really the original name of NATA. It was founded in 1998 in Graz, Austria. It was branded as the Network for the Advancement of Transfusion Alternatives. Think of this. This again is something shocking for healthcare, because at the time everybody thought that blood was life-saving no matter what. So the original founding charter, technically the Article of Association, was drawn up under the French Association law. So it became mostly a French-driven organization. Excuse me. The purpose of this association was to promote training and education in alternatives to blood transfusion. Again, very thoughtful. Advancing medical and scientific research in the relevant disciplines, again, in the relevant disciplines of alternatives to blood transfusion. developing and sustaining high-level international scientific cooperation, working with others, especially those organizations that were promoting blood, addressing the medical, legal, and ethical aspects of these techniques. Think of this. This clearly adds another dimension to medical education. Not only are you looking at this from a clinical as well as scientific approach, but we now added another dimension, which is looking at why we do things, or again, resonating with clinicians, their duty in terms of doing the right thing for patients and learning how it is we do the right thing for patients. So there was an added value of joining bloodless medicine and surgery. Nata created a journal which was called Transfusion Alternatives in Transfusion Medicine. This was launched in 1999 and was the official organ, but is no longer in print today. So the unmet medical need, as we mentioned at the beginning, is to deliver bloodless care. It is not about withholding blood. It's about the full knowledge of blood. This is about knowledge of practice. If you want to practice bloodless, many clinicians feel that it's just withholding blood as part of their care. But in fact, no, we need to understand blood. You just heard two talks before me. One had to do with hyperbaric medicine. And here again, S. Kelly did a great job presenting this, but you could see that we're working with the part of oxygen delivery, which is again not driven by hemoglobin. And we had to do this again, so we had to understand all of the components of blood. So again, this adds another layer, if you will, to increase the repertoire of any clinician, the importance again of joining bloodless medicine surgery. And then there were many publications trying to put all this together. You see the two from Nata on the left. These were books, Transfusion Medicine, second edition, again, Transfusion Medicine and Alternatives to Blood Transfusion was another very large book that was put together. Here's a picture of the Tandem, which was the journal, which, as I mentioned, was no longer in print. And the two major basic books that were put out by SAPM, looking at the basics of patient blood management, but started off with bloodless medicine and surgery. And these two, again, there was the first and second edition. This all culminated in, again, going back to the patient and having them understand of how to participate in their care when it comes to their blood health, which is the blood works. As bloodless medicine and surgery became organized, it needed a definition. We did come up with a definition that was not agreed upon, but I think reflects what we do when we treat bloodless patients. And the intent here was to understand to improve patient outcome with the use of clinical strategies for their medical and surgical care without the use of allogeneic blood components. Should be actually not blood products, but at the time that's what we looked at. And again, you see this is a multimodality approach. The fact of the matter is that this definition resembles the patient blood management definition in many ways, although we evolved to get the patient blood management definition to be, again, global definition. I put an asterisk next to use of allogeneic blood products, meaning without the use of allogeneic blood products, because that was considered to be outside the standard of care. Now, in fact, this is not experimental anyway, but we had to be very careful to understand what it is that we were doing for patients for whom blood transfusions were not an option. So one of the things we had to do is look at this from a global point of view and understand who benefits from bloodless care. So we know that patients for whom blood is not an option include Jehovah's Witnesses, but now we've recruited other patients. Those patients who have received large numbers of transfusion have become alloimmune and therefore cannot receive the transfusions, again, become bloodless in many ways. But there's also another level, which is when blood is not available. And this includes both military and civilian injuries. You could bring blood to the front line, whether it be military or civilian injuries, but that amount of blood may be very restricted. In fact, once that's used, these patients become bloodless. And we need to think of that in terms of bloodless and how we manage them when blood is no longer an option, meaning it's no longer available. And already mentioned to you before, when we look at the two HIV and hepatitis C epidemic, when blood becomes unsafe. And let me just state this emphatically, is if you think that these two issues, meaning HIV and hepatitis C, are no longer a threat, we live every day with the possibility of a new agent becoming a threat that may, again, prevail in our blood system. And it takes time for us to recognize that it may be transmitted through transfusion, and it may cause deadly disease. Now, another statement I'll make is that all engaged practitioners, all patients treated by them, and overall the practice medicine, this has been clearly something that adds huge value to any clinician who participates in a bloodless medicine and surgery as a clinical practice. I already mentioned before that some data that we've had published actually goes beyond equivalence, or that it's not superior, but in fact, superiority is not shown, but in fact, you could see that there have been some publications, which I'm going to go through very quickly because of time, that show that there is superiority to that. Now, we step on the fact that this is not just a delivery of care, but this also recognizing the patient have a choice. And bloodless medicine and surgery in many ways has enriched patient autonomy. Patient autonomy was central to the organizations that were developed for bloodless medicine and surgery. NATA was one of them. And I already went through this with some of you in the past at the BMS conferences, looking at the evolution of medical ethics, which we think about as being something new, but in fact, not new at all. You could see how old the issue of medical ethics, if we want to call it that, or the duty of clinicians has gone back, and it spans all cultures, not just the Western world, as you could see with the Hippocratic Oath, but also Chinese and Indian medicine, as well as medieval Islamic medicine. So this has touched everywhere. And there's significant overlap in terms of the duty of clinicians and understanding where clinicians interact with a patient. Again, the evolution is there. I'm not going to go through that, but most of us today live with the ramification of what happened around World War II with the Nuremberg Code. And of course, from 1979 and 80, the publications by Duchamp and Childress on autonomy, beneficence, non-malfeasance, and justice. Those four principles clearly were always highlighted with bloodless medicine and surgery, and remain the core of medical practice today. So the problem is that none of these issues address the vulnerable patient per se. So medicine has been paternalistic in many ways and for many years, and still remains an issue. There is a strong sense of belief among physicians and other healthcare providers that blood clearly is the answer for many ailments. Alternative medicine and treatments considered unscientific, and those providing them are charlatans. So again, the word alternatives became a challenge for us, especially with NATA. Again, mentioned to you before, the issue of refusing the standard of care despite the lack of evidence for a standard of care created conflict between healthcare providers and the healthcare system and patients. Those choosing to refrain from receiving blood transfusion were deemed to be heretics in the Cathedral of Medicine, and I'm quoting here the late Ken Kipnis, who clearly help us understand our duties as clinicians, but also the ethical ramifications of not addressing the needs of patients, including those for whom blood is not an option. So bloodless medicine and surgery focus on clinician, on their duties as clinician, not to cooperate, but to serve. The right to choose of patients clearly is a major concept that has been brought forward by BMS. The right to adhere to one's own principles, again, brought forward by BMS. easy extrapolation to other clinical scenarios. So again, the repertoire of any clinician who deals with bloodless medicine and surgery is expanded considerably. Force feeding, sustaining organ function when deemed infutile. Those of you who do critical care know that these are major concerns. Defining vulnerabilities, subjects that are being now recruited for trials. There are many trials out there where the thoughts in terms of whether the subjects are vulnerable or not is being overlooked. We need to, again, bring focus to that. And lastly, BMS, bloodless men surgery clinicians, able to better cope with these ethical issues because, again, as we've seen with COVID, there are always going to be ethical issues that rise to the surface, regardless of what we're faced with. COVID was one of them. And again, those individuals who had the background of bloodless men surgery can cope with these ethical issues because they are armed with now new repertoire and information. So the summary of this is that those clinicians who embrace bloodless medicine and surgery, each one of them will report a positive and learning experience that has helped them with the general population. So going back to the evolution of organizations, and then after Nata came Sabam, which was established in 2000. Again, there were many bloodless clinicians who initiated this organization function. Again, the rest is history, or is it? Well, in 2011, the establishment of the Bloodless Men and Surgery Society in Calabar, Nigeria. Hello to everyone. Again, thank you for putting this one together. The charter here was advancing the science of bloodless medicine. So again, we can have a scientific approach to bloodless medicine and surgery. And just to read, the Charter of Bloodless Men and Surgery Society is an international multidisciplinary society of experts in blood transfusion avoidance. Founded in 2015, it is a unique medical society committed to improving clinical outcome and protecting patient rights by promoting techniques of total avoidance of allogeneic blood transfusion based on current scientific evidence. Again, you could see how the melding of ethical commitment to care with the science behind it can actually not be practical, but add to the repertoire of any clinician. Well, yes, it's not just physicians who were first in line. This brings to us the first organization by Sharon Vernon in 1996, which was NABMS. This was a nurses organization dealing with bloodless medicine and surgery. As you could see, a strong commitment to BMS, strong commitment to educate. The docs did not like it because, again, this was educated by physicians, the nurses were, but in fact, a lot of nurses took over and created a very strong organization that still resonates today in terms of the contribution of not only early contribution of nurses to bloodless men and surgery and the evolution of patient blood management, but also the strength of this particular part of the medical discipline today to promote this. So bloodless and the clinician's mind, you can understand recognizing the unmet medical needs of those who decline blood transfusion. Already mentioned this multiple times, recognize the vulnerability of this population. Again, that's span off to other patients who are vulnerable, as already listed. Recognizing the limitation of allogeneic transfusions, clearly benefit-risk ratio is still a component of confusion for many clinicians today. The need for scientific validation of patient blood management was early on and carries to today, uncovering the potential patients on blood and expanding the benefits of BMS for all patients and expanding both horizons and repertoire of clinicians. You can get better than this. We talk about patient blood management being win-win-win from clinical medicine. There's no more win-win than this particular discipline. So the importance of bloodless medicine and surgery already mentioned in terms of medical needs for patient decline transfusion, the limitations of allogeneic blood, and of course the evidence of potential benefits, extensive scientific validation over 20 years or more. And this again comes together to build this concept of patient blood management, which brings us back to the foundation of bloodless medicine and surgery as the foundation for patient blood management. And you could see that the aspects encourage clinicians to work with patients at the center, allowing them to form their care plan. Patient-centered decision-making clearly is invaluable because it allows us to focus the patient on their goals for their healthcare and align us with their goals in terms of what they're looking for healthcare. Allowing patients at the center of the care empowers them to be in control. It doesn't mean that they direct their care, but clearly they're bringing the concept of what it is that's important to them and how we need to maneuver with understanding that importance. Thus, the concept of blood health, which is the ultimate, if you will, in terms of the goal of both us as clinicians, but also more importantly, the goal of the patient. And blood health and patient-centered decision-making are all founded, if you could see, under the foundation of bloodless medicine and surgery with an interim stop at patient blood management. So the foundation that leads to the crown being a blood health. In conclusion, the importance of laying a foundation was described. It opened new horizons in medicine for patients and those of providers. The unanswered and unmet medical need, again, is a rare form, if you will, when putting it together. If you look at other unmet medical needs in healthcare, none have had the benefit an organization that does both the science as well as the ethic and moral obligations to patients. Reduce the vulnerability of many patients. Again, many are able now to get care that is the appropriate care for them, which again focuses on their goals for their care and understanding again what it is that they need and don't need. It contributed to the welfare of many who would not accept blood or blood transfusion as part of their therapy. And it invigorated ethical principles for all clinicians who deliver bloodless medicine and surgery. Let me just leave you the one thought, which is the future will be brighter if all patient blood management clinicians were to embrace bloodless medicine and surgery. So if you have a program in your institution or healthcare organization, and you're delivering bloodless medicine, you're delivering patient blood management, one, again, you need to look back and to embrace bloodless medicine surgery as well, because this will enhance anything that you do with PBM by having, again, bloodless medicine surgery as part of your repertoire. So with that, I thank you, and I'm leaving you with my, again, email in case people have added question at the end of this session.
Thank you, Ari, for a wonderful talk, and thanks to all the speakers. We have about 6 minutes before the next session begins. So members of the panel can either raise their hand or just unmute. And everybody else in the audience can use the Q&A function, and I will relay the questions to the appropriate speaker.
I can start with a question for Dr. Johnson Arbor while we're collecting those in the Q&A. Thank you for that really inspiring discussion of hyperbaric oxygen therapy. I'm wondering why you think it is that most hospitals in most countries do not have a hyperbaric oxygen program. Is this something that's very expensive to begin, and or does it occupy much space? And then I also was wondering if you've ever used that multi-patient chamber for how many patients? What's the maximum number you've had in there?
Yeah, so those are both great questions. I'll start with I guess the second one is probably the easiest to answer. So yeah, right now I work in a single person chamber facility, but for 10 years I worked in a multi-person chamber facility. That's a lot of fun. It's a very different lifestyle. You're doing critical care, you're up all night taking care of neck fashion, whatever else. The occupancy varies based on the type of chamber. So our chamber could hold 10 patients. Right now in Maryland, University of Maryland Shock Trauma, their multi-place chamber can hold, I think, about 15 patients. So it really depends on the chamber. Some of them have like 2 or 3 units put together. UPenn has this like huge system where they can fit like 30 patients into their multi-lock, multi-person chamber. So those are out there, but they're rare and they're more common overseas. I think Israel has a lot of them. There's a lot of great hyperbaric research that comes from the Middle Eastern region because they have embraced the use of hyperbarics more. In the US, hyperbarics is frequently considered to be a treatment in search of a disease, is how I've heard it expressed before. And really, the main uses have been for wound care. And that's I'm not sure why. I mean, for the last 20 years, most of the hyperbaric centers that I have been involved with have focused on wound care. That's probably because diabetic foot wounds are, were sort of initially marketed as the like a main option for hyperbarics. In my experience, those patients don't do well because by the time that they get referred to us, they're already at the end stage of their disease, and putting them in a hyperbaric chamber for 2 months is not going to change their risk of amputation. But I think overall, most of the hyperbaric centers in the US are used for wound care, and they're there. You may not know that they're there, but they're kind of tucked in the back of the outpatient wound center. And in my hospital, some people don't even know that we exist because we're like in the back of the wound center. Nobody knows where we are. One time we had to call a code because one of our patients passed out. Like the code team couldn't even find us. Like the ICU came down like 10 minutes after the fact. And I was like, oh yeah, we're taking this patient to the ED already. We're like wheeling her down the hall when the ICU team came down. So I think there is a great deal of great lack of awareness overall about hyperbarics and how it can be used. But the chambers are around, but they are mostly used for wound care.
Thank you so much.
Belinda, if I can add, being a hyperbaric physician myself, yeah, actually, Kelly, absolutely right. There's some other issues in terms of managing the service. So to make it profitable, yes, you need wound care because there's a whole issue in terms of the expense for hospital to send, but also the infrastructure maintaining the chambers and having that done is pretty expensive for hospitals. So initiating that, you really need to have the population. Again, the other problem, of course, is that like many other services, when it becomes an outpatient service like a wound care, it becomes sort of a 5 days a week, 9 to 5. But as Kelly did so well in her presentation, you could see that many of these patients could be emergent or emergency patients that need again hyperbaric therapy, and for that you need to have a service that's 24/7. So there's a conflict there. Because if you have somebody in need, whether it be a diver or whether it be somebody who's got any other condition that fits into hyperbaric, if you don't have that service at 2 o'clock in the morning, you are, again, that becomes a real conflict for the clinicians who are working with hyperbaric.
Yeah, and the 24/7 chambers are harder and harder to find in the US. Those facilities do not make money. So I will say, like, the majority of my patients are not wound patients at this point. We do a lot of other treatments here that do not involve wound care at all. But most in the US, most of the hyperbaric facilities focus on diabetic wound care. One of the reasons is that you can bring those patients in for 2 months and you can bill 2 months of facility fees and make a lot of money that way. And so wound care itself does not make money. The hyperbaric facilities can make money to support the wound center. So it is largely financial. And there's a bunch of third-party organizations out there that will come in and manage your hyperbaric facility. For the cost of the chambers, I forgot to mention that a single person chamber can run maybe, I don't know, like a couple $100,000. The multi-person chambers are going to run in the millions. And so those are very expensive to put in, very expensive to maintain. You got to have 24/7 coverage for them. Those are decreasing a lot in the US. I think as of my last count, which was a few years ago, there were only about 50 something 24/7 hyperbaric facilities in the entire US. Those facilities are closing year by year because they just do not make money. It's great to be able to be there 24/7 and treat scuba divers and carbon monoxide and whatever else. But the reality is you're making your money from your daily wound treatments, not from the, once a month scuba diver or carbon monoxide or anemic patient that you treat at 2 a.m. So yeah, those facilities are having a lot of financial difficulties.
One other
Fascinating.
area that is a problem is making the science, doing studies with hyperbaric. Again, do you use patients who are not in a chamber as control? Well, that's very different, right? So that's already a problem. The other is when you can't really pressurize patients with air to that extent. It has to be oxygen. So you can imagine that trying to separate pressure from the oxygen tension is going to be very difficult. So adding to the science has become a major challenge in terms of doing randomized controlled trials. So where a lot of times we're looking at experience with it, and there's a lot of controversy, even amongst us in hyperbaric in terms of the science.
So thank you.
Thank you.
We're 1 minute beyond where we should have been, thanks to everybody catching up. So
I'm sorry, I think Johnson is up.
Another
Dr.
question.
Waters.
pardon?
Get some
Dr.
sleep.
Waters, Dr. Waters' hand is up.
Well, it was.
Jonathan,
I mean, if we're behind schedule, I can defer.
Go
It's
ahead.
fine.
Go ahead. Go ahead, John.
no, yeah.
Well, I was going to ask Dr. Kaufman or Margit. She presented three non-invasive mechanisms for measuring hemoglobin, and I was wondering if she has adapted those tools for her clinical world, given their lack of sensitivity and specificity.
So we did. We put a non-invasive SP hemoglobin monitor in a few of our surgeons' offices. It was mixed results. It wasn't great. What I was told was if it said they were anemic, it was usually right, and they knew to send the patient immediately for labs. But there was many times that the patient was anemic, but the hemoglobin monitor said they were not. And so then there wasn't the same urgency that occurred. But there is literature that it's a mix of that. So that was the biggest one we had was from our GYN oncologist. He still uses it actually today. He still appreciates having the information.
Dr.
Thank
Odian,
you so
did you have a
much.
question? You
We have
had
another hand up.
yeah.
Yeah, thank you very much. Can you hear me?
I have one question for you, Dr. Johnson Arbor. So, was this ever used in sickle cell disease patients where sometimes we don't have blood for them until we be able to get them any blood?
I'd love to use it for sickle cell patients that are alloimmunized because sometimes you can't get blood for several days. Those patients do great. You just put them in hyperbarics until the blood arrives. Or if there's no blood, you just treat them until they're symptomatically better. I actually just finished a sickle cell patient last week. We've had great outcomes with those patients, and they're always like really grateful that there's another option out there. On a similar tangent, red blood cells theoretically only sickle when they're hypoxic. So if you place a sickle cell patient under hyperoxic conditions, their sickling should get better and their pain should get better. So in the US, we can't use hyperbarics to treat sickle cell pain because it's not going to be considered medically necessary by insurance for such, but it is sort of a secondary outcome that I will discuss with sickle cell patients when I treat them for their anemia. But yeah, they're a great patient population to use with hyperbarics.
Great, thank you.
Now we do have to wrap up in a minute. I think there's a question that Dr. Shander may receive an email about because it seems like it is a kind of a long answer. But the question is, how do you distinguish PBM physicians or clinicians from BMS clinicians? And the recommended answer was to email you to ask that, but if you could answer it in less than a minute, we'd love to hear.
The only distinction between the two is the commitment to, again, the general population of patients versus those for whom blood is not an option. That is the only distinction. Again, the commitment on both sides is very important. I just feel that, again, if you have an independent patient blood management program in your institution, you need to, again, learn about BMS and open your doors again to that population in an organized fashion. And I think that many patient blood management organizations overlook the population that can benefit from BMS.
Absolutely.
So
Well, thank you very
Dr.
much.
Sue has added some interesting comments here. He's a pediatric hematologist, and he said in sickle cell anemia, hyperbaric treatment will suppress erythropoietin and red cell production, so one needs to monitor the level of anemia for iatrogenic worsening of anemia, or to perhaps consider giving erythropoietin during the hyperbaric treatment. Obviously, this requires a kind of level of expertise that most of us don't have.
Well, I don't know that that's necessarily true, though. I wonder, does Dr. Sue, do you have a reference for that? Because, since intermittent hypoxia triggers EPO, we have seen anecdotally in our institution that patients with acute blood loss anemia tend to recover their hemoglobin concentrations faster with intermittent hyperoxia / hypoxia with hyperbarics. So I have not studied this in the sickle cell population. I have not seen sickle cell patients actually have a reduction in their response to EPO with hyperbarics. But again, I haven't studied this formally. But if you have any references, I would love to, if you could put it in the chat so I could go over them.
This could be actually studied easily. This is something that may lend itself to be able to demonstrate that scientifically, if you will, and published, and maybe go beyond just the hyperbaric publications, meaning into the general medical. That'll be very interesting to see. The big interplay, of course, that we've had is that hyperbaric oxygen does cause peripheral vasoconstriction. And that is one of the issues that we had to deal with in terms of patients who are severely anemic, because the microcirculation is where we're really addressing the increase in oxygen dissolution. So that improves, but at the same time, if you're shutting down beds, that may actually be detrimental. So there's an enormous amount of play there, which again is very difficult scientifically to demonstrate. So we're leaning on theory.
Well, I'd like to thank everyone. This was a fascinating session. Thank you to our esteemed speakers and the meeting organizers for putting this together. So now I'd like to conclude this session and introduce the next one, the Art and Science of Bloodless Medicine session that will be moderated by Dr. Mark Friedman and Sandy Mann.
All right. Hello, everyone. My name is Dr. Mark Friedman. I'm an associate professor and blood bank medical director here in the NYU Langone Health System in New York. And I guess my job is to introduce Sandra Mann, whose bio I don't have, so I'll just let her introduce herself.
Thank you so much, Dr. Friedman. Actually, I was going to go ahead and do the same. Welcome everyone to a very special session. This morning has been so inspiring, and yet we have a few more speakers who are going to really deliver some uplifting deliveries. At this time, we're going to do the Art and Sciences of Bloodless Medicine. I'm Sandy Mann. I've been a nurse for about 25 years. 15 plus years of those have been dedicated to the passion that we all share today, which is bloodless care, patient blood management as well. Right, currently I'm exploring a position with Triage Nursing and Triage Now, but formerly Mercy Hospital Systems, and then prior to that, Flower and Toledo Hospital Systems up in Ohio. And so I'm going to go ahead and introduce my co-moderator again, Dr. Friedman, Dr. Mark Friedman. He's a clinical associate professor of pathology, medical director, transfusion service for NYU Langone Hospital, Long Island, and NYU Grossman, Long Island of School of Medicine, Department of Pathology in Mineola, New York, USA. Go ahead, Mark.
Okay. Again, I don't really have any script here to go by. So,
are you able to introduce our Art of Science in Bloodless Medicine and Sherry Ozawa, or?
Again, I don't have any of the bios, but I do. Of course, Sherry Ozawa is very well known.
Sandy has the bio, so Sandy can go through it.
Okay.
Absolutely. So thank you, Dr. Friedman. So basically, this session that we are doing now, this is a session where we get to do the art and science of bloodless medicine. And that gives us the opportunity to have insight not only into our speakers, but their extracurricular activities. It brings out the personality of our professionals, so to speak. And many of you may be very familiar with Sherry Ozawa. She is really one of the faces of patient blood management and bloodless care, and one of the pioneers, along with our founders, right? So I'm just going to go ahead and pull up her bio, which is really a comprehensive here. But Sherry
You don't
Ozawa.
have to read it, Sandy. It's okay.
I just want to bring in a few highlights, actually.
Okay.
Sherry, I do want to recognize you because you
Thank
have
you.
worked so hard. Really, you are globally recognized now, and you are truly a representer for bloodless care, bloodless medicine, and patient blood management as well. But today we are focusing on bloodless medicine. And right now you are working with HC1. But one of the things I want to bring out is that you have played a pivotal role in developing and leading one of the world's most successful and widely recognized multidisciplinary bloodless and PBM programs at Inglewood Health in New Jersey. And I believe those were the roots that really made you who you are today in our industry. But currently, I know you serve as the Director of Comprehensive Patient Blood Management, Delivery, and Operations of HC1, which is a US-based company specializing in implementing patient blood management programs nationwide. So I do want to go ahead and let you take the wheel there and share with us what you have. And your presentation today, and everyone, I think we'll enjoy this, is Bloodless Medicine and Surgery Programs, the Ultimate Multidisciplinary Symphony.
Thank you, Sandy. I'm going to share my screen. I'm trying to actually share some sound, but it's not giving me that option on the share sound section here on the share. So I'm not sure how well we'll be able to do with that. I don't know if the our organizer.
Before you actually share the slide, Sherry, you can look at the bottom part. You see share sound, or depending, you can look to the side.
I do see it, but it's not allowing me to do that on this particular one. So I don't know if it will work or if it's defaulted to share sound, but it's not. It's grayed out for me that I can't share it. But in any case, that's okay. We will go forward. I'll try to, when I get to that slide, we'll try to play it. And if it doesn't work, it doesn't work. That's okay. So here we go. Okay. Is everybody able to see that slide?
Yes.
Okay, perfect. Thank you, Sandy, for the kind introduction. And thank you to Nat, certainly, and the organizers for inviting me today and for your kind and generous words before we got started. So I've been asked today though this is a meeting that has focused heavily on technology. My part is actually sort of not technology focused, and as Sandy and Dr. Friedman pointed out, is more on the artistic part, perhaps, of bloodless medicine and surgery at the heart of this. Of course, we bring some PBM into this as well because of all the things that Dr. Chandra just explained to us. But I was asked to speak about the symphony that is bloodless medicine and surgery. So thank you again for that kind invitation, and congratulations to all the excellent speakers on this session and the ones that came before me. So several months ago at the previous BMSS conference, I was also kindly asked to speak on the subject of the art of bloodless medicine and surgery as a potter. But actually, I'm not a potter. I'm not sure how that got out into the into the public space, that this was my background. As wonderful as that is, it actually is not my background. But as Sandy well pointed out, I do have a background actually as a concert cellist from childhood on through adulthood. Of course, now this is a hobby and not a profession, but I still retain my passion and interest, of course, in this field. And the idea of the symphony orchestra and the way that musicians work together actually is quite inspiring to me in my practice in bloodless and inpatient blood management. Actually, the picture on the right are several of my physician colleagues who are also involved both in PBM and in a local orchestra that I still continue to play with. So the point is not an autobiography, but really how do we tie together the art of what I think we can learn from the way a symphony orchestra works together, and tie that back to bloodless. So Susan, you've heard a lot of excellent technology-oriented talks and very, very scientifically oriented talks. This is less so and a little more conceptual. So please bear with it, but I hope you get some ideas out of it and hopefully some inspiration, as Sandy well stated. So I don't know how much any on the call have been part of. I'm sure some of you also have your own musical history and background, but if you've ever been to a symphony orchestra, you know that it's a sort of a complex group of folks that somehow all get it together and produce a beautiful rendition of whatever the composer intended to be. But it doesn't happen just on the day of performance. As much that goes into it. So we're going to kind of create over the next 20 minutes or so a metaphor of how this relates to bloodless care and what we can learn from our musician friends and colleagues out there and our symphony orchestras that applies to our science. Again, a little conceptual, but I hope you find it interesting. So this actually is a picture of the New York Philharmonic, my personal favorite orchestra, my local one. But let's talk a little bit about the elements of a symphonic performance and make that metaphor to what we do in the coordinated multidisciplinary care of bloodless patients, because that's what I was asked to speak on. So as you know, in a symphonic performance, whatever kind of piece they're playing, there is a conductor. A lot of times people who don't know a lot about symphonies, orchestras say, what is that person doing there? Sort of waving their arms around. Of course, we'll talk more about that, but in our metaphor, the conductor actually is the patient. And I'll explain in a moment why I feel that that's really the right metaphor for that. We have a score, right, where that conductor is aware of all the different parts that are going on, but that really is a piece of the patient's life to me in this metaphor while we are taking care of that patient. And there are lots of sections in an orchestra, strings, bass, woodwinds, percussion, etc. These are, to me, are sections of the healthcare team responsible for playing this piece. The stage is any healthcare setting, right? And we all work in lots of them. And the audience, really, who are we playing to? We want that patient to go back home to their loved ones, to their family. So again, kind of a weird metaphor, but let's go with it for a moment for the next few minutes. So what do I perceive in the bloodless world, the patient as our conductor? Well, we always say patient-centered care, right? Well, what does that really mean in this context? Well, it means that the values and decisions and directives really set the tempo, the ones that come from the patient of our medical team. And we are honoring their score, their personal and medical wishes at each step of the way. And of course, tie this again back in your mind to everything you know about bloodless care and everything we've heard this week. This really is, right, based on these patient-centered values that we hold so dear in bloodless. And the approach is to build on this foundation of shared decision-making and a deep respect for patient autonomy. I would say we all agree with that, but let's look at that patient sort of as the conductor of everything that goes on around them. Now, you've seen probably this context before. This isn't specifically about Bloodless. This is how the Institute of Medicine, which is now here in the United States called the National Academy of Medicine, defines patient and person-centered care in the context of PBM or Bloodless, we'll say. And I won't read every word, but same principles. But this is really defined in the literature. This is just a nebulous concept that patients are at the center of what we do. But it really says that we are guided by those patients' life experiences, stories, and knowledge, and respect their individual values and put them in the center of what we do, and that we fully engage with our patients and their families in meaningful ways. And again, those all sound like nice words, but what do they really mean in application? And I think Bloodless has really brought that to life. So let's go back to this idea of the multidisciplinary team, which again is, to me, this large symphony orchestra playing together where every part is crucial. So this is defined in the literature too. What does a multidisciplinary team mean? We say the word all the time. I think we think what it means, but what the literature tells us, it's a group of professionals, healthcare professionals with diverse areas of expertise who collaborate to provide the best possible patient care. So I think that, though, I'll just take a moment to pause here and say that we sort of interchange the way we use the word multidisciplinary and multi-professional. I think often working with my physician colleagues over these years, I know that I think to their ears, they hear multidisciplinary, and often we think, well, that means an anesthesiologist, a surgeon, oncologist, an ED physician, an endocrinologist, whatever that may be. But then really when we talk about Bloodless and PBM, often we're really talking about all of that, but we're also talking about multi-professional teams, right? Social workers, nutritionists, etc. So they're not exactly interchangeable terms. We kind of use them interchangeably, but I think it's important to remember that when it comes to Bloodless and PBM, we really are talking about both. So I just pulled this from the most recent, you've seen this, of course, many times over this week, the most recent WHO guidance document. And this was just a nice image that shows that we are talking about both multidisciplinarity and multi-professionalism when we approach PBM. But the same is true of Bloodless, again, because Bloodless served as the foundation for everywhere we have come now in these 3 decades to PBM. So why is multidisciplinary care desirable? Some of that may seem obvious, but we actually have studied this in the literature. Why is it important to work together as a team, not just in words, but in actions? Well, there's some concrete reasons. It actually improves the patient experience. It maintains well-being in the workplace, which is a critical issue now for healthcare providers, their environments, and retaining workforce is an extremely important issue around the world. It creates a psychologically informed environment, contributes towards progress towards self-actualization and the sort of the Maslow hierarchy. This actually, as serving as part of a team, actually makes us individually progress more towards self-actualization and reduces patient mortality, complications, readmissions. It actually optimizes utilization of ancillary services and a lot of other benefits. But at a high level, multidisciplinarity is not just a nice concept. It actually has been shown to improve many things about our patients' outcome and experience. So this is not a specific Bloodless or PBM paper, but I thought this was an interesting piece from the literature, which looked at a perspective on barriers and facilitators of multidisciplinary care when we work in teams. And so we're used to, probably in the more quantitative literature, looking at these large meta-analysis. So we don't as often look, I think, in the same way as our qualitative research literature, but it's just as valuable, of course, just a different type of research. So in this way, versus looking at a meta-analysis, we're looking at a meta-synthesis. So long story short, this was 17 studies that looked in an interpretive way at the findings in multidisciplinary teamwork as what fosters it or what hinders it, with a reliable methodology, so that we were trying to compare apples to apples, and looked at the perspectives and experiences and factors of members of the healthcare team, and really what worked and didn't work, what drove change and didn't drive change in multidisciplinary care. So the results were, and again, this is a complex study, but I'll just keep it very high level, that there were 4 main things that affect our ability to work effectively as multidisciplinary and multi-professional teams, organizational, individual, and collaborative variables and role variables. So we can get deeply into each of these, but I'll sum it up. This was, I think, a really interesting diagram from this particular metasynthesis, and I'll highlight sort of the second gray columns. Those are those 4 sections of variables that affect our multidisciplinary care. But anything in green was really considered a facilitator to multidisciplinary care. And I would argue that Bloodless really was an early model of true multidisciplinary care, which again, we throw the word around and we use it all the time now. But I think we modeled it in Bloodless a very long time ago. And I'll talk more about that in a minute. But you look in that gray section on these variables that are facilitators to teamwork and multidisciplinary care, and think about how this relates to Bloodless and where it is and where it came from. These listening skills, external and internal motivators, right? Like those belief systems of the patient, et cetera, respect, and the other areas in green, teamwork, role clarity, et cetera. But I think that really, again, Bloodless speaks perfectly to why did it serve as an early model and a current model of ideal multidisciplinary and multi-professional care, because it hits really on all these facilitating buttons. Another not very colorful image from a nice piece of literature on multidisciplinary care. This is really multi-professional care. And in the rounding model, many of us are part of these multidisciplinary rounds, perhaps in our organizations. But again, tied the outcomes to this, that this isn't just a nice thing that we all work together, but it actually absolutely does decrease mortality rates, complications, near miss events, some of the very, very important factors that we are always trying to achieve, and makes a lot of things better. Our patient experience, use of ancillary staff satisfaction, et cetera. So there's really some strong evidence in the literature that these multidisciplinary approaches and multi-professional approaches are good for the staff, good for the medical teams, good for the patients. So I think we know that, but that's really been studied. So let's go back to where we started with Bloodless. So I said a moment ago that really Bloodless, I think, created an early model or an ideal model of multidisciplinary care. So let's walk through this just for a moment and think about it. So unique to Bloodless care, right? The patient requires specific clinical planning to meet their personal requirements, whether those are for religious reasons, whatever the reasons are, it doesn't matter. But before the idea of Bloodless being an organized effort, care was really isolated to a single specialist or a specialty, right? So a patient would see perhaps a surgeon because they were in need of a procedure or whatever intervention they needed. And that person would determine, I can or I can't work with this restriction or this concept or in a Bloodless way. Let me maybe query my colleagues. Maybe I don't even get that far. Maybe I just can't get past this thing in my own mind. And that's really where many of us started decades ago in Bloodless. And unfortunately, that still happens sometimes. Now, how does that relate to where I think Bloodless modeled multidisciplinary and multi-professional care? Well, with Bloodless in our left lower quadrant here, multiple disciplines and professionals are necessary to meet the complex clinical goals. Not that we just want to, the population deserves it, right? That's why this population initially sought this type of care, and programs like Englewood and now so many others formed was to create this web of multidisciplinary care. And the range actually may be wider with the Bloodless patient, right? We always want a multidisciplinary team for all patients, not just Bloodless patients, but there may be additional issues or complexities raised in a Bloodless case where we might involve others that we might not as typically involve, bioethicists, perhaps a child life specialist, maybe even finance folks, as we're looking at patients who move geographically to different places to seek Bloodless care. So it may actually be a larger web that we weave with the Bloodless patient. But again, I think the early and ideal model of multidisciplinary and multi-professional care. This is not meant to be a history story of Englewood Health, but something very early. I think this is 1990. I don't want to date myself even further than I'm already dated, but really back to the heart of it. This was meeting the needs of a community in a very specific way. That's why that started, that continues, but we look to see how far we've come with this foundation and what has been built on, as Dr. Shander initially said. So if we follow that, again, with sort of, it looks kind of like a complex diagram, but if we start from the top, right, we have at the top a patient that we know transfusion is not an option for whatever reason. On the right side, in a non-bloodless world, a pre-bloodless world, maybe the patient seeks care from, I called it a surgeon, it could be any practitioner where the patient needs some intervention. No multidisciplinary team formed. That it may stop there. Can't do it, don't want to do it, not sure how to do it, don't know if I have a team. The left side, in a bloodless environment where we have an organized program, now we have novel resources and literature, which perhaps we didn't have 25 or 30 years ago when many of us got started. We have a surgeon or an interventionalist or a provider with a team working along with them. And then the green boxes that follow. That patient may need anemia management, specialty consultation, all different strategies to address their blood health, novel techniques, which may be technology oriented, etc. And then we have, and I think the ideal setting, a bloodless coordinator, person could have different titles, sort of pulling these things together into this multidisciplinary team. In the end, we hopefully end up with a successful surgery and procedure, which then leads to new knowledge, which points back up to the literature and resources. So the team not only accomplishes what they need to for this patient, but also contributes to the larger literature. And with that, I just also have included, this is something from SABM, but we use this as a PBM, and I included Bloodless Manager Director job description. Of course, because of my background and many on the call, I do feel like this role is critical in a successful bloodless program and as part of that team. And I just highlighted a few words where this job description or this role really pulls together that MDT, that multidisciplinary team. So ensuring alignment, integration, overseeing multi-level education, serving on different committees with all of these colleagues, and coordinating, facilitating communication. I think my slide got cut off, but amongst the different members of the team. So what does that really look like in the real world? These different PBM/bloodless leadership roles. Sometimes they're called a coordinator, navigator. I see some folks in attendance that have different titles like this, and anemia management coordinator, PBM, bloodless director. Sometimes it's a transfusion safety officer or leader with PBM roles. The titles don't matter as much as what this person does, again, in coordinating the team. So I'm not thinking my videos may not work, but I'm going to give it a shot. I don't know if it is going to play. I don't know if we can hear this. Is the sound working at all?
Schneider has your slides, and he's ready to put it on for where you need the sound.
Okay. Well, so I mean, it's not critical, but this is where I'd love to put the sound.
So yeah, we want to hear it. So you can stop your share, and he will start sharing.
Okay.
Question of what the concert master is asked.
Can you guys hear it?
Very often, because quite frankly.
Yes.
Yes.
You heard it?
Yes, heard it? But yeah, you stopped the share.
Okay.
So while he's starting to share again, I'll just mention what is on this slide. If you've not been part of a symphony orchestra, which probably most of us have not, there's another role that a lot of people don't understand, and that is actually the role of the concert master. And you may have seen that person comes out. What does that person really do? They have a different level of responsibility. And again, we're kind of in an extended metaphor here, but I really view that bloodless or PBM coordinator director as actually the concert master. So I have a little clip here from Glenn Dicterow from the New York Philharmonic, who I got to personally meet several times. He's an amazing person, now retired. But if we hit play on that one, it'll tell you a little bit about what that person does. Okay, we don't have to play the whole thing.
Put up the volume.
Because quite frankly, it's I don't know how the name got started here in America, because in Europe, certainly in England, they call you the leader. Maybe this term concert master was a way to differentiate between a conductor and a principal player. What do we do as concert masters? We play all the solos that are written for concert master for the solo violin. We make
I think the sound is gone. I don't know. That's okay. If you can hit the second video, maybe hit our little guy underneath. It's another point, and we'll just make a point. Not from the beginning, right where he's at. I don't hear any sound. I don't know if anybody else hears sound.
Did you share sound?
We can try it again.
If not, it's okay. No big deal.
Grayed out for me as well.
Okay, so we'll just make the point. That's okay. I can share back my slides. Thank you for trying to do that. It's no problem. I will just speak to it. So really this is an interesting role, and what these two conductors are essentially saying that it's a role that, again, a lot of folks not involved with the symphony may not know about, but this person has the extra level of responsibility where they essentially make sure everything is running well. You may have seen, if you've ever gone to a symphony, that person comes out first. He actually introduces the conductor, who in our metaphor is our patient, right? Everything centers around the patient. They are really, in a sense, directing what happens with all of our sections, but they make sure everything is ready for the conductor, and they facilitate the attendance of each person. They tune up the orchestra. They make sure everybody has the resources they need and they're ready. So the conductor then shows up, who in our metaphor is really the patient. The roles together are brought together by the concert master for the performance. The second video, which we couldn't hear again, for the technical issues, but he tells us from a different symphony that another role, if you've ever gone to a symphony performance, and you're not going to be able to perhaps to hear the video on this next slide to hear the noise, but you will see that person is also responsible actually to coordinate what we call in the string section the bowings. So you probably have seen a symphony orchestra. If you don't, you will in a second, where all the instruments work together, the stringed instruments, all those bows are moving in the same direction. That doesn't happen by accident. That actually takes a lot of planning. If you could hear this video, you would recognize Beethoven's Fifth Symphony, but even without sound, since our sound is not working on Zoom, you will be able to see the bowing. If you watch these musical string performers bowing, you can watch that they all move in the same direction. So you get the point, even if you can't hear the sound. So again, maybe a little bit out there in terms of a metaphor, but to me, this is really the role of that Bloodless coordinator, often an undersung role, but they pull together all these pieces on the day of performance to make sure that we have accomplished what we need to for the patient. So now my time is really up here, finish up this interesting metaphor, but on the day of surgery, right, all these different disciplines come together to perform the conductor. That's our patient, their piece. This concert master has prepared the section. What does our Bloodless coordinator do or director do? Make sure that the individual needs of that patient, their advanced directive, the patient choices, right, are in tune, that everyone is aware, communication's been synced up, resources are available, and the patient stays at the center of our multidisciplinary team and the conduit. So all these folks come together to perform what is this beautiful piece of music, and it all works together in this multi-professional, multidisciplinary way. Again, not a history lesson from the past, but one of our early pictures at Englewood, where our patient sits at the center. Of course, you recognize Dr. Shander, Dr. Perlman, you may know, and part of our interesting and long history, but the basis, again, of this was our patient at the center of our multidisciplinary team. So I think to sum it up in a word, Bloodless medicine and surgery is this harmonious, evidence-based approach at performance where every musician plays a coordinated part to achieve the best possible results. So when we see these things, I just pulled these. I can't capture them all anymore, but many of our colleague partners, some on the call, who have bravely put forward their bloodless medicine and surgery programs, oftentimes in concert with their PBM programs all around the world, all around the country. What I really see, and what I hope we all see, are these beautiful orchestras, these symphonies that work together as multidisciplinary teams. So again, a little out there metaphor, but thank you for this chance and the technology conference to talk about the artistic parts of bloodless medicine.
Thank you so much, Sherry, for sharing that with us. Just tying in symphony and how it actually orchestrating it, and the concert master, how he ties in with bloodless care, the patient blood management as well. The coordination is just amazing. If you're not involved with that, you really, would not really understand the detail that goes into a beautiful concert. And I also would like to thank you for correcting us about your passion being really about being a cellist and not a potter, so that we don't always remember you as the potter. Sherry the potter. Yes, and also just bringing your own personality to life. So, many of us might think that you actually breathe bloodless medicine and patient blood management 24/7, but no, Sherry, there's a lot more to you. You're very multifaceted, and we really appreciated that. Dr. Friedman, are you able to pull up the bio for our next speaker?
Unfortunately, I was not sent any of the bios.
Okay, no problem.
You could check your chat, see if you found anything.
Chats.
Yeah.
I want to pull this up. Well, in the chats, I don't see anything.
Okay, not to worry. Sandy can go on there.
Yeah, no worries, Dr. Friedman.
Sorry.
So at this time, we're going to introduce our next speaker, and that would be Dr. Pereira. Dr. Pereira, I want to pronounce your first name. I believe it is Thales or Thales. I apologize if I'm not pronouncing that correctly, but I do want to say that Dr. Pereira, currently he practices at Hospital São Camilo Pompeo and the Brazilian Institute for Cancer Control, which is IBCC, two reference centers for complex oncologic and hematologic treatment. His clinical expertise includes the care of patients undergoing autologous and allogeneic stem cell transplantation, patient blood management, transfusion alternatives, aplastic anemia, myelodysplastic syndromes, leukemias, and post-transplant complications. That's quite an impressive bio there, Dr. Pereira. Today, he's going to be focusing on how that all plays in with bloodless medicine, and his talk is titled "Bloodless Bone Marrow Transplant: The Scientific Solution to Some Serious Challenges in Blood Health." So thank you for that, Dr. Pereira. Go ahead.
Oh, thank you. Good morning. My name is Thales. You actually did a great job pronouncing it. I think it's more of a Brazilian used name. I'll share my slides so we can start the presentation. Do you guys see my slides?
Not yet.
For some reason, I'm having some trouble sending you guys the slides. Let me try it.
Schneider, do you have his slide?
I will look for it.
So Thales, if you click on share in the middle, and
I did it already. I know.
So then you search. I guess your slide is open already. Your slides are open. So you search for your slides among those files.
If needed, Dr. Pereira, I think I have your slides.
Okay, let me just try one more time.
Here we go. We can see them now.
Okay.
I'll just put them on a slideshow. Yes.
Okay.
Here we go.
And are you guys seeing it correctly now?
Yes.
Okay, so I'll start. My name is Thales Pereira. I am a hematologist and a stem cell transplanter here in São Paulo, Brazil. And today we're going to talk a little bit about some of the techniques we use to perform stem cell transplant in the context of a patient blood management. I'd like to start by defining what this procedure actually is. So hematopoietic stem cell transplant is a medical procedure that replaces disease or deficient bone marrow with healthy cells with the aim of reconstituting the patient's cell production and immune system. The most common indications for stem cell transplant these days are acute leukemias, some aggressive and relapsed lymphomas, multiple myeloma, severe aplastic anemia, some hereditary blood diseases such as sickle cell anemia, and some aggressive and relapsed germinative cell tumors. We basically have two groups of stem cell transplant, and we will choose between these groups depending on the indication of the transplant. The first big group would be the autologous one. In this group, the patient will receive stem cells from himself. And the other group is the allogeneic group. The patient will receive cells from a donor. This donor can be 100% matched and can be from the same family or an unrelated donor. Sometimes in the context of a donor from the same family, we can use a haploidentical donor, which means that the donor is only 50% available with great results. The sources of stem cells can be collected from the bone marrow with aspiration, direct aspiration. We can also, and this is the technique we use the most these days, collect peripheral stem cells with anapheresis, and we rarely do it, but it's possible to do a stem cell transplant using umbilical cord stem cells. This is mostly used in the pediatric scenario these days. When we indicate the transplant for a patient, we go through different stages. We first, at an outpatient stage, when we choose the type of transplant this patient is going to have been done. We choose the best donor available. We choose the source of stem cells. Most of these indications will be done related with the disease the patient have. And then after the hospitalization, this patient will go through a conditioning regimen with chemotherapy. Then we will do the infusion of stem cells, and we will wait 2 or 4 weeks to the engraftment. And why would we do bloodless stem cell transplant? Well, the main reason is because a lot of patients decline transfusion for different reasons. We also, especially in lower income countries such as Brazil, we might face blood shortage sometimes. And we also know very well the risk of transfusion reactions that we can face. But is it possible to perform stem cell transplant using PBM techniques? And the answer is yes. And we have, at this point in time, real world evidence that it works, and it works really well. We do face some challenges though. When performing stem cell transplant, we'll face at least a small grade of anemia and thrombocytopenia. There is a risk of hemorrhage, and also we can face infections, and sometimes the engraftment is a little bit slower than we would like. So this might lead to the patient not feeling very well throughout the process. We try to overcome these problems with the pillars of patient blood management, which is recommended by the World Health Organization and also by the Brazilian Federal Medical Council, which our team is a part of. And we do so by trying to stimulate erythropoiesis very early. We usually start the stimulation medication a day after the infusion of cells. We try to reduce the intensity of the chemotherapy we do before the transplant. We try to select the least cytotoxic possible prophylaxis for graft versus host disease. We also try to reduce the blood loss. And in some cases, we use antifibrinolytics and some drugs to try and make the engraftment period a little bit shorter, which I'll talk a little bit more about later in the presentation. So I'll start by what we do as stimulators for the erythropoiesis. We maintain RO, B12, and folinic acid supply throughout the entire process. We do so even when we have normal lab results, dosage of these things before the transplant. And we treat the patients like they have chronic inflammatory anemia. We also perform alpha-poietin. Our dosage usually is 40,000 units per week. We do so until the patient has a hemoglobin of 12. We suspend it if it goes higher than that because of the data we have of the choir trial, where it showed that if we continue to do so after this endpoint, we might make the risk of a thrombotic event very high. We also, as I said, keep using intravenous iron. We have multiple presentations. Our preferred here is pharyngect. We usually do it once a week, and we usually perform it at least 2 times before engraftment. We also do agonists of thrombopoietin receptor. We have 2 different ones available. We have eltrombopag and romiplostin. Even though the data of using both drugs at the same time is lacking a little bit, we have performed them together and we have achieved great results in doing so. The main reason we think is because they are stimulating the thrombopoietin receptor in different areas. So they might have a synergistic action. We usually start eltrombopag 50 milligrams per day and romiplostin 1 nanogram per kilo a week. And we are used to increase this dosage with the goal of the platelets being maintained over 50,000 during the entire process of the transplant. Other thing we keep our eyes on is minimizing the blood loss. We do so by reduce the volume of sampling. We do use pediatric tubes even in adults. We also take longer intervals between samplings. So we do usually every 72 hours. We try to avoid collecting labs through the central line, and we also perform other labs only when necessary. In case of younger women, we also do menstrual suppression before the procedure. And when this patient have any evidence of bleeding, we use antifibrinolytics and vitamin K and other strategies depending on the situation. And we prevent infection so the patient can better tolerate the period of anemia after the transplant. We do so by taking really good care of the catheter. We also use prophylaxis for virus and fungus. And in some cases, we use granulocyte colony stimulating factor. We know that this drug can potentially reduce the platelets or make the time for platelet engraftment a little bit longer. So we don't use it all the time, but when we see that the engraftment period is maybe taking a little bit longer than we used to, we might consider this drug. And where do all this information come from? It started in the early 2000s with the teams in the US and in Italy. And here in Brazil, we also started in the early 2000s. Our very first patient that had received a stem cell transplant in the context of patient blood management was in 2004, a 15-year-old female girl that had refractory Hodgkin's lymphoma. She had an indication for autologous transplant. At the time, we consulted with the teams in the US and Italy. We studied and applied the techniques, and the transplant was a success. The first publication we did on this was in 2006, and it had a really big media repercussion here in Brazil. After that, we've been getting more and more experience. We did 2 other big publications. The last one was last year when we had 42 patients transplanted without any blood transfusion. And currently we have over 50 patients transplanted without receiving any type of blood transfusion, 52 to be exact at this very day. So I'll talk a little bit about our 20-year experience. Most of the patients that we transplanted had multiple myeloma, but we already transplanted patients with pretty much every indication there is for stem cell transplant. Most of these transplants were autologous, which is compatible with the literature. The conditioning regimen that we used most of the time had reduced intensity, as we can see in the red, but sometimes we even perform non-myeloablative regimens, we can see in green, which is even less toxic, and we can use in cases of disease such as sickle cell anemia, for example. We have performed transplant without transfusion in a very wide range of ages. Our youngest patient had 2 years old, and our oldest had 71. And this is probably my favorite data that we have. Our overall survival in the first 100 days, which would be the most critical period after the transplant, is very, very, very comparable to the overall literature in this team, showing that we probably have results just as good with and without blood transfusion. This is a longer curve. We did an analysis of the overall survival of our patients in 10 years, and it's also really, really good. And I would just like to point out that even though it's really, really rare, in cases of imminent risk of death related to severe cytopenias, for example, a patient that is bleeding, and we have already performed all of our available techniques of the PBM, we do offer the possibility of blood transfusion, but this, of course, is not obligatory, and these patients have, here in Brazil, the right to deny, and it's protected by law. This is our team that work with stem cell transplant and PBM in Brazil. And this is what I had to say. Thank you so much for the invitation. I'll leave my contact information, and I'm available to answer any questions.
All right, I guess we're looking for questions. Let's see.
Well, Dr. Friedman is looking at the questions real quick. Dr. Pereira, just want to thank you for that beautiful presentation, helping us understand how stem cell therapy can be done, bloodless, and the survival rate. And I really appreciated how you had mentioned how one of your big interventions really is preventing infection.
Yeah, I
yes,
think it's, go ahead.
I'm sorry. One of our biggest goals, we know that the patients go through a period of severe immunosuppression after the transplant, and they can develop infections. And when we do the prophylaxis, they can withstand the state of anemia and thrombocytopenia a lot better.
Interesting.
Thank you. There is one question here from Dr. Su. How many have you performed with sickle cell anemia?
I'm sorry, the number?
It just says how many with sickle cell anemia. I guess if have you done many with sickle cell anemia? I know that's a relatively new area where we're doing stem cell transplants.
Yes, it's a new area, even in the context of transfusion patients, but we do have already transplanted patient with sickle cell anemia without transfusion. It was a child. I am more in the adult sector here in our group, but we did perform it and it was successful. The number is actually 2 cases that I remember.
Yeah, I know that's a relatively new indication here also in the US. So I think it's very interesting and certainly innovative that you can perform these stem cells without giving transfusions, especially the way that you're using some of these growth factors like the TPOs. I think is very innovative because I know that a lot of these patients tend to get a lot of platelets and then they run into platelet refractory issues, and giving the TPO can certainly decrease that risk.
There is one question from Susan, Mark. She has her hand raised.
Oh, okay. Sure. So go ahead.
Hi. Congratulations to both of you, Sherry and Dr. Pereira. Excellent talks. My question is for Dr. Pereira. I understand that bloodless BMT is rare in Brazil and that your team, together with Dr. Roberto and Dr. Christina, are leaders in this field. So how are cases managed when treating Jehovah's Witnesses or other patients for whom blood is not an option? And how is the multidisciplinary team trained to handle such situations in your institution in Brazil?
Thank you for your question. Yeah, I'd like to start by answering the first one. How we handle. We do have some things that we consider for this specific group of patients. As I said in the presentation, we go through different stages in this transplant, in this stem cell transplant. We, for example, would do things like reducing the intensity of the chemotherapy before the transplant happens. Sometimes it can lead, we know, to a higher degree of relapse rate, but we also protect the patients from being exposed to severe cytopenia. But this is something we do. For example, we also, when treating the patient to make them available to the transplant, we are using a lot more target drugs. So we can, for example, in the context of an acute lymphoblastic leukemia, we had in the past only chemotherapy available. Now we have drugs that are targeting some specific clusters that make the treatment a lot less toxic. So we do all of these things. And we also try to make them get into the transplant with the best levels of hemoglobin and platelets possible. So sometimes we offer them, for example, the TPO agonists before the transplant. So the platelets would be higher when we start the procedure. So it makes the procedure a lot safer. And I think I answered a little bit of the first question. And going to the second question, how do we treat our multidisciplinary team? As you've said, we are the biggest group in Brazil that do a transplant in the context of patient blood management. So when someone comes to work with our team, this person is trained from the beginning to better attend all the patients' needs. And we do have a big team with us that includes odontologists, nutritionists, physiotherapists, and all of these people are trained to deal with this kind of patient specific.
Thank you.
Mark, I'm not sure if you see it. There's one question in the Q&A session.
Okay. No, I'm not seeing that. Okay, yeah, I'm not. Oh, Q&A. Okay. Yes, it says, what did you say that you are doing to combat hypercoagulability? I'm assuming that this is for Dr. Pereira.
Okay, we try and be responsible with the use of antifibrinolytics. We do not use them as a prophylactic manner. We know that some groups do. So this is something that there is a little bit of debate in this area, but we think that this might potentially increase the risk of thrombosis, so we don't do it. Also, when we are stimulating the erythropoiesis, as I said in the presentation, we do offer the patient alpha-poietin at the dosage of 40,000 units per week, but we are only doing it until the hemoglobin hits a level of 12 because of the data of the QUARA trial that showed that there is an increase in thrombosis in this scenario. So we try and take these measures. I think that for the patient doing a stem cell transplant in the context of PBM, our main concern is hemorrhage, more so than we are concerned with thrombosis. This is very rarely. I've never seen it, to be honest, but we do take those kind of cares to avoid it.
Thank you for that explanation. Okay, I don't believe I'm seeing any other questions.
There is one. Somebody raised their hand.
Okay.
Susan, do you have another question, or that was the old one?
I do.
Oh, go ahead.
I do. And this question is for Sherry. Sherry, based on your experience collaborating with PBM. Oh, sorry. Can you see me? Can you see my video?
No,
I don't. I see
there.
Yeah.
So based on your experience collaborating with PBM coordinators around the world, what do you consider to be the major obstacles they face in other countries?
Wow, thank you, Susan. Good question. I think and again, a little caveat, I may take it a bit from a nursing perspective, because I think many of us involved in the coordinator, director, PBM, Bloodless role are nurses, not necessarily. But I think it's to me, the biggest challenge is the structure of healthcare systems and the variability of that, where nurses, but certainly others, function in very different scopes of practice and setting levels. So where in the United States, for example, it's not difficult or unusual for a nurse to be at a very advanced practice level, for example, even be a CEO of a health system, or be a fairly independent provider. Trying to describe that model in many other parts of the world is completely unknown and out of sorts. And I think the big challenge I've seen is the very hierarchical health systems in different parts of the world, where there isn't really everybody will use the word multidisciplinary and multi-professional, but what we really see in application often is, a very physician-focused, physician-led initiative in PBM, where, with all due respect, I sometimes think there's sort of lip service paid. I don't think it's disrespect per se, but sometimes teams can't really figure out what that role would be for that PBM or Bloodless coordinator. So I think something in SABM, and Susan, we've had these conversations, and many on this call, is that we have to further develop. I think when we say this is the role of a physician, of course, there's variability across the world in different countries to some degree, but it's a reasonably well-defined area of practice in terms of diagnosis, treatment, intervention, whether it's surgical or medical, et cetera. there's a lot more variability in the non-physician PBM potential roles. So I think those are the big challenges, that it's much more variable, hierarchical systems, and the very different way healthcare systems are delivered in a US model, for example, where so much is driven by the payment systems and the payers, and very, very little governmental oversight, versus other countries. There's a lot of governmental oversight and a lot of that kind of structure built in. So I hope that answered the question.
Thank you.
Okay, thank you for that. All right. I'm not seeing any other questions at this. Oh, here. What are the solutions to this? I guess I'm not going to follow up the question.
Denise, I guess it's a solution to my answer. I mean,
yeah,
we need lots of solutions in PBN all over the place. I think that as we further develop scopes of practice, I'll just give you one example. You heard this maybe presented if you were at the SABA meeting 2 years ago. There are a group of nurses leading an effort with the American Nursing Association, which does have some global footprint. And this is just an example, and this is not all about nursing, but where we have actually submitted a pretty complex process to this organization, which is, the governing specialty defining organization for nursing, for example, in the United States, of patient blood management as an emerging nursing specialty, just the way that, and this is not necessarily true in other countries. I know that kind of structure doesn't exist, but the same way that physicians can subspecialize, right? So, an anesthesiologist then can subspecialize to be a pediatric anesthesiologist or cardiac anesthesiologist, etc. The same exists in nursing with credentials and accreditation that accompanies that. So, for example, a nurse can specialize as an oncology nurse, not just because that person says, well, I work in oncology. There's obviously criteria, work experience, proficiency, etc., that are associated with that. So we've submitted that application to the American Nursing Association to say, can we define patient blood management as an emerging nursing specialty? Again, this is not just about nursing. I'm using that as an example, where we really start to attach a name and a scope to it, so that PBM doesn't become, or Bloodless doesn't become, this sort of nebulous thing that these do good, very well-meaning, like many of us on the call, maybe very academically advanced, scientifically oriented folks are in, but in a somewhat disparate, sort of disorganized way in some cases. So I think following recognized pathways, like certification, accreditation, regulatory bodies, sometimes that's no fun, right? Those processes can be cumbersome and difficult, and they're not perfect. But I think that's part of the solution, is kind of, in a way, mainstreaming. Bloodless and PBM, right, started in a very non-mainstream way, but that's okay. That's the beauty of it. So I think though following some of those mainstream processes so that it's recognized in that way, I think is part of, there's no single solution, but I think that's part of it.
And thank you. Okay. Don't believe there's any other questions at this point, but I do want to thank the speakers. I think these are very interesting talks, and I think we're probably a little bit over anyway. So thank you.
Thank you, Dr. Friedman, for handling those Q&A questions for us. So at this time, we're going to bring our Q&A to a close. Like Dr. Friedman said, we want to kind of stay on time here for everyone. But as the General Secretary for BMSS, Bloodless Medicine and Surgery Society, I really want to take this moment to thank all of the speakers that have been presenting just wonderful talks this last 3 days, the panelists that have also supported us, the attendees. Without you, we would just not be the program that we are, the conference that we are, and the co-moderators that all helped in introducing and supporting the presentations as well. And behind the scenes, so much goes into one of these conferences. It's really amazing when you're trying to help coordinate this. So we really want to thank all of those that are the members of the BMSS Society and our former president, Nathaniel Usoro, who truly has been a workhorse making this happen. So at this time, I want to go ahead and call on our new BMSS, or Bloodless Medicine and Surgery Society president, Dr. Christopher Simotuo. And we're honored to have you take it from here.
Thank you very much, Sandyman. And I would like to urge all the attendees, members and non-members, to stay on for this annual meeting. It will be brief so that you just get to know the few things about the Bloodless Medicine and Surgery Society. Schneider, can you help share the slides? Thank you very much. So briefly, we'll just briefly look at the review for BMSS 2024. Then we'll briefly discuss the updates of BMSS. And then we'll see who's going to get the BMSS award for 2025. Then we'll also briefly look at the BMSS 2026 for next year, and briefly discuss if there's any other business. To review the Bloodless Medicine Surgery for 2024, we normally have two main meetings, the Bloodless Week, which we hold in May, and also the annual meeting in November. Last year, 2024, the chairman for the meetings was Dr. Jonathan Waters, and the secretary was Becky Rock. And during the Bloodless Week of May 13 to May 18, the topic was on bloodless care in oncology and the palliative care. We had quite good meetings during this time, and such that like evidence against blood transfusion, palliative care in oncology, and the use of IV iron in oncology. During the meeting that we had in November, the annual meeting, November 6 to 8, the main topic was medical informatics, advancing bloodless medicine. We had key presentations like evidence from big data and machine learning, and the medical informatics, advancing bloodless care. All these presentations are still available on YouTube. The next item again, it's on updates. Schneider. So the update that is available to share is that all medical students, including nursing students, pharmacy students, and other allied medical students, are now free to join Bloodless Medicine and Surgical Society. There's no payment for them now. It's free so that they can get to know and be on board with advances in bloodless medicine and the surgery. Yes, Schneider. The next item is on the precious award. The BMS 2025 award.
No, there's a slide he has skipped just before about this.
Okay, you just go backwards.
There's a slide before this. After this. Next slide. That's it. It keeps jumping.
There's not another slide for that after that one.
You
Okay,
had
hang on. Let me
you
see
had
if I can share it from here. Okay. I think it's you are actually sharing it, but that okay, the slide before this. Yes.
It's basically, it highlights the Bloodless Medicine and Surgery Society, showing this description that the Bloodless Medicine and Surgery Society is an international multidisciplinary society of experts and stakeholders in blood transfusion avoidance, which was founded in 2015. And the mission for this is that to bring home the benefits of current scientific evidence in blood transfusion avoidance to patients and clinicians all over the world by encouraging the teaching and practice of bloodless medicine and surgery, as well as research and dissemination of scientific information on BMS. The vision: to establish bloodless care as the global standard of care for ethical and evidence-based practice of medicine rather than an alternative. On the membership, currently we have more than 200 multidisciplinary membership from 5 continents, which is very good. Okay. Now we can go to the next slide.
Next slide. Keep advancing them to get to the end.
Okay. The next slide is on organizational affiliates.
Nathaniel, if you wanted to share that, because I don't have any other slides after that one.
Okay, let me look for it. It's actually there, and you showed it. But
It's on organizational affiliates showing BMSS and SABAM and the Malaysian Society of Patient Blood Management.
Yeah, it's right there after the description of BMSS.
Yeah.
Aha,
Yes,
that's it.
these are organizational affiliates for the Bloodless Medicine and Surgical Society. As you have seen, even from the presentations during this week's, the excellent presentations, that yesterday we had mostly our colleagues from the Malaysian Society of Patient Blood Management, and today we had presenters mostly from SABAM. We had excellent affiliates helping the BMS to move forward. Okay, Schneider, can you get to the award? Is that the first slide?
You see the slide?
Yes, can you have the next one? The BMS Award of Excellence is normally, this was instituted in 2015. The award is for an individual or an organization with a track record of outstanding contributions to the science and practice of bloodless medicine and surgery. The awardee must have a track record of outstanding contributions to the science and practice of bloodless medicine and surgery in any or all of the following areas: academic, clinical, and advocacy. Next slide. For 2025, the Board of Trustees have awarded Nathaniel Osoro, a Chief Consultant General Surgeon, Chief Consultant General Surgeon in University of Calabar Teaching Hospital in Nigeria, who is also a fellow of the West African College of Surgeons and a fellow of the International College of Surgeons. He is a founding president of Bloodless Medicine and Surgery Society and instituted the teaching of blood conservation and blood surgery to medical students and residents in his institution in 2014. Possibly, I think, possibly in Africa, I think that's the only university where this is part of the curriculum in teaching medical students. Nathaniel Schneider, next slide. Nathaniel is the founding chairman of the Bloodless Medicine and Surgery Group in University of Calabar Teaching Hospital, a multidisciplinary group of professional volunteers providing bloodless care for patients with excellent outcomes since 2007. Is a member of several international professional societies, including the Society for the Advancement of Blood Management, where he serves in the membership committee. He is a recipient of several awards, including the 2016 Sabam Kathleen J. Sazam Award for outstanding leadership in advancing patients' rights in patient blood management. Next slide. He has presented several papers on the subject of bloodless medicine and surgery in international professional meetings, published in renowned peer-reviewed journals, and has a book chapter to his name. He's very passionate about improving clinical outcomes and protecting patients' rights through blood transfusion avoidance. So for 2025 award goes to Nathaniel Osoro. Do you have another slide? The one showing the actual certificate award. Yes, thank you very much. So to all attendees, may I present to you Nathaniel Osoro, who is the Bloodless Medicine and Surgery Society Award of Excellence for 2025. Nathaniel Osoro. Dr. Osoro, do you have any comments to make for your award?
Well, I'm actually quite overwhelmed and very grateful for this award. I'm very grateful to the president, Mr. Christopher Simutoe. I have to address him as Mr. because he's a fellow of the Royal College of Surgeons of Ireland and of Edinburgh, so they answer Mr. So I'm very grateful also to the Board of Trustees and the members of BMSS who nominated me. I happen to know a few of them that nominated me because without their nomination, I wouldn't have been given this award. It's a very, very important award for me. Schneider, could you stop the slideshow? Okay. So I think it's, in my mind, the most important award that I've ever received. And I'm very happy that it is Chris that is giving me the award, because the idea of BMSS started in his country, in Zambia, when I visited Zambia. I think that was in 2011. And from there, we then got the society. And of course, as he has pointed out, our aim has been to try and sensitize the whole world about the need for bloodless medicine and surgery, not just for patients that decline blood transfusion, but for all patients. As Dr. Refai told us, I think it was on Monday, that some patients go to hospital and claim to be Jehovah's Witnesses just because they want bloodless care. Either they don't want the problems of blood transfusion, or they have heard that bloodless care is superior, which it is. And we've been able to hold meetings every year without a break. This is our 11th meeting. And finally, I have an award from the society, and I am very, very grateful for it. I think this is an encouragement for me to work harder and not relent in any way. So I'm so thankful. Let me stop there. Thank you so much, everyone.
Congratulations, Nathaniel.
Thank you,
Thank
Nathaniel.
you.
I'm sure we'll have more discussions about this, Nathaniel, but let's proceed. Can you have the next slide again, Schneider? 2026. For 2026. Thank you very much. We are all aware about the World Health Organization published the urgent need for PBM in 2021. And if we listen to Dr. Shanda's presentations, we can conclude that there is really an urgent need to implement BMS worldwide. And we will discuss that need and how we can work to meet next year's need. Hence, for 2026, the urgent need to implement bloodless medicine. And this is marked for November 4 to 6. So we are all inviting you to please come and attend and actively participate in next year's annual meeting. I think the next item on the agenda is any other business. Any of the colleagues who have any other business, there's something I would like to contribute. If there aren't, then I will call upon the chairman for this meeting, Rafael Majed, to give his closing remarks. Rafael.
Thank you very much, guys. It was really I consider it very successful conference. And I would like to take a moment to thank all the participation first from our audience. Thank you for joining us, and a special thanks to our speakers who share their knowledge and skills with us for free, actually. They just volunteered to share it with us. So we really appreciate your time and effort. I want to also thank our organizers, the annual meeting organizers, sponsors, and volunteers for their work, effort, and commitment to come up with a very successful meeting. Special thanks to our president and to our founder, Dr. Nathaniel Osoro, and our president, Mr. Christopher Simoto. Thank you all again, and I look forward to seeing you next year, 2026.
Well said. Thank you, everyone. I want to thank the committee, especially, and Dr. Osoro for all of the assistance to make this such a successful conference the last 3 days. So thank you again, and very excited about next year.
And Majed, please, before we go, can we have a group picture?
Sure. Yeah.
So,
congratulations, awardee, and to everybody.
thank you, Abigail. I know you must be one of those that voted for me.
Don't forget to smile.
Everybody ready?
Put starch on your smile.
And we have it. There we go. That's it.
Great job, everyone. Thank you.
Oh, great job. Nathaniel, so well deserved. How exciting that was.
Congratulations.
Thank you,
Yes.
Sandy.
Yes.
And Jamila is not here. I should thank her also.
Everyone, this was just such a wonderful conference. Every one of them is always tops the last year's, although every year is so good. So this has just been so inspiring. Schneider,
need to-
thanks for
we need
keeping
to try
everything afloat.
We need to start earlier, probably, Nathaniel, maybe at 5 o'clock in USA. I'm just kidding.
Yeah, it's quite a challenge because we want to start earlier. We end up leaving out people like
Malaysia.
Dave. No, Malaysia will be happy. Dave in Vancouver will not he'll be snoring a second time at that time. And then we want to make it later, and Mandy will be fast asleep. So we keep it at 12 GMT so that it can be sort of balanced.
Yeah.
I don't know where Dr. Sue stands on this.
Acceptable for me. Much earlier would be really hard. Thank you.
Yeah.
Thanks
Thank
for
you very
having me.
much.
Good job. Congratulations, everybody.
Thank you, guys.
I should thank you. And thank you very much, everyone. I really appreciate it. So have a lovely weekend and a nice time until next year.
See you next year.
Thank you all.